Good morning. We will go ahead and start in just a moment or two. We're just waiting on folks to join. It's 9:03, so I think we've maybe waited our sufficient allotment of time for everyone to join. Welcome to the fourth Health IT Leadership Roundtable. We are so pleased to have such a distinguished group of speakers on our agenda today, but also to have so much interest in the event and so much participation from those of you at home or at work joining us online. Today, as I mentioned, we have a great and fantastic lineup of speakers. We will be joined by administration officials, congressional staff, in just a few moments, actually, the CEOs of some of the most preeminent organizations here in DC, and then also throughout the day, private sector leaders who are leading their organizations and understanding how to harness data in the future to support the use cases of public health and health equity. Two use cases that have really, over the past year or so here, risen as far as top of the list of priorities of things to be addressed in the near term with healthcare, data, and technology. So before I introduce our first session here, which will be the Executive Roundtable, I wanted to give a brief overview of the Health IT Leadership Roundtable and go over the agenda in a little bit more detail, and then also address a few housekeeping items. For those of you who aren't familiar, the Health IT Leadership Roundtable is a group of organizations that have come together. You can see our host committee here. These organizations have really come together to discuss key policy issues related to health IT and to identify areas of consensus where future action, either by the private sector, but also by federal and state lawmakers, where additional action can really sort of smooth the road to the future that we know is out there if we harness data and technology to their maximum capacity. So the purpose of today's event is to bring organizations with a variety of different perspectives together to talk about our shared commitments and a roadmap for the vision of health IT. And today, using public health and health IT as sort of the framing for the broader discussion. You can see our list. I mentioned these are our host committee members. We are so thankful for their partnership and ongoing support of our initiative and work here. I did want to point out we have several new host committee members for those of you who have joined past events. So we were very pleased to welcome the American Medical Group Association, AMGA, and the Medical Group Management Association, MGMA, to our host committee for this event. And we're looking forward to working with them and all of our other host committee members going forward. So I think the next on the agenda here is the agenda. So let's take a look at today's agenda so that you know what to expect. I know sometimes a 3-hour virtual event, you may have to go in and out. So I just want to quickly run through the agenda. Next up will be our executive roundtable, our CEO roundtable, harnessing data to advance health analytics. We are so pleased to be joined by Washington Post reporter Rachel Rabin. So we will turn to that very quickly next. Following that roundtable discussion, we will have a session on perspectives from Congress on data and health equity. We are very pleased to be joined by both House and Senate staffers to have a discussion about what's on tap for Congress and how they are thinking about these important issues. We will follow that with a session from with an administration official. So Catherine Okar is Special Assistant to the President, and we'll be talking about public health and health disparities and the administration's perspective on those issues. And then following that, we will move into 2 panels. And we are, as I mentioned, so pleased to have leaders from the private sector to talk with us about these important issues. So the first panel will be on advancing health equity through health data and infrastructure. And the second panel will be modernizing and advancing public health. And then we will wrap up at the end. Any key takeaways and conclusions as we go on about our day here. So a couple additional housekeeping items, and then I promise we'll get to the main event. We are on Twitter today, so we will be tweeting from the handle that you see there, HIT Roundtable. We are also recording today's webinar. The event recording will be available shortly after today's session on the website that you see there. We will also email it out to all of our attendees here today. So you should be getting a link in your inbox in the next few days. I also wanted to point out several of our speakers will be taking question and answer from the audience. So if you have a question, please feel free to use the Q&A feature down at the bottom, and we will answer, insofar as time permits. If we don't get to your question, maybe we'll try to collect them and, make sure that they're addressed somewhere along the way. But we do encourage you, we want this to be as interactive as possible, both between and amongst the panelists, but also the panelists in the audience. So please do send any questions in, and we will answer them as we can. And also, I wanted to mention the press. So we do have several members of the press joining us today. Any inquiries you can send to Crystal at the email box there, and we can connect you with our panelists or provide any follow-up materials as needed. Okay, I think that's it as far as the opening, level setting and housekeeping. So without further ado, I will turn it over and do a brief intro of our first session here, which is our executive panel, Harnessing Data to Advance Health Outcomes. As I mentioned, we are here today to talk about our collective vision for the future of health IT and to consider specifically how data can, and in some cases will be used in newer, better, faster, more robust ways to improve our public health response and to improve health equality. So, I think it's clear, and these folks, I'm sure, as the conversation proceeds, will highlight how data and technology are being used amongst their respective constituents, the folks that they represent here in DC and across the country, to improve the patient experience and to tackle some of these tough policy issues. So I will turn it over now to Rachel Rubin. Rachel is a national health policy reporter with the Washington Post. The folks that we have on our panel here today, they'll introduce themselves, but just quickly go through their titles and their organizations. So we are so pleased to have Ramsey Alwyn, the President and Chief Executive of the National Council on Aging, Sean Martin, the Executive Vice President and Chief Executive Officer of the American Academy of Family Physicians, and Sean Robbins, Executive Vice President of External Affairs at the Blue Cross Blue Shield Association. So, Rachel, I turn it over to you, and thank you to everyone for participating here today.
Hi, good morning, everybody. Thanks for being here. I'm excited to dive into the conversation, but first we're just going to hear brief 2 to 3 minute remarks from each panelist. So Ramsey, let's start with you.
Well, it's a pleasure. Thank you, and good morning, everyone. Thank you so very much for having me. I'm Ramsey Alwyn, the President and CEO of the National Council on Aging. We are a 70-year-old national nonprofit working to make aging well possible for every person. We work with national and local partners across the country focused on achieving equity in aging, so every individual has the health and financial security they need to age with dignity, purpose, and security. To us, that basic health and that financial security shouldn't be based on luck or any other factor out of one's control. Our systems should be built to ensure everyone has the gift of the quality of years and the quantity of years they desire. Unfortunately, that's not the reality today, and we see every day far too many older adults are struggling. The pandemic put a spotlight on this. It showed us in stark headlines that the systemic barriers, the market gaps, the long overdue modernization of many of our systems make it nearly impossible for too many to age well, especially women, communities of color, low income, rural, and LGBTQ communities. At the National Council on Aging, we are committed to working to ensure we center our efforts on these populations because they are more likely to experience a decline in health at an earlier age, face higher rates of social isolation, and live at or near poverty levels. They often lack access to culturally competent services and supports. And at NCOA, we're working to change that. We want to raise up these stories and call for all to center their work on the populations that have been left behind far too long. As with the Public Health Network, those of us in the Aging Services Network have seen firsthand how these inequalities can keep too many older adults from being able to thrive, age with dignity, contribute to their local communities, their families, and our economy. So we're so thrilled to be here together to talk about a multi-sectoral opportunity for all of us to work together to change that, create the systems that support and empower individuals with trusted information, engaging community-based organizations that serve older adults and those that care for them, so that we can truly get everyone on a path to age well. Thanks so much for having me today.
Sean Martin, let's go to you next.
Sure. Thank you, Rachel, and good morning, everybody. I am pleased also to be here today with Ramsey and Sean for this important discussion with all of you. My name is Sean Martin, and I'm the Executive Vice President and CEO of the American Academy of Family Physicians. The AAFP represents about 134,000 family physicians and medical students across the country. Family physicians are unique in their service to the community. The last time I checked, the AAFP and our members had a footprint in about 96 or 97% of U.S. counties. So we are literally everywhere across the country providing care to populations, both rural and urban, young and old. The unique aspect of family medicine that so uniquely positions our members in the healthcare workforce is the span of care that they provide across a lifetime, from birth and infants all the way through into life and our seniors. So a little bit about the Academy. As Ramsey said, I think the pandemic really brought to light a few things for us. First of all, just the pure heroism of physicians, nurses, and other healthcare professionals across the country that stepped up and continue to step up every day to provide care to individuals and communities across this country, and trying to help communities combat the pandemic, a pandemic of misinformation, and create a culture of health that helps people live their best lives and healthiest lives. But we also saw some opportunities for improvement that were brought to light. Obviously, we're going to have a conversation here today about health equity. I think the pandemic brought into sharper focus some of the disparities that have existed for a long time in our healthcare system, but certainly provided us a new opportunity to focus on them in a different way that's more solution-oriented. I think it also showed us the important aspect of distribution of information, whether that be health information or scientific information across the healthcare industry, to all providers of all type, to all patients of all types and all locations, so that people are operating from a consistent basis of information that avoids confusion in times that, quite honestly, are sometimes quite chaotic. And I'll leave with this around data collection. I think crisis often sharpens focus, and I think one of the things that the pandemic has taught us is really focusing on actionable data and actionable information versus just kind of flooding the healthcare system with information that may not have a purity of purpose at the given moment. And I think this is going to be one of the valuable lessons as we think about public health moving forward, is really the purity of data that is actionable at the point of care, or actionable in the community, versus just kind of this broad sweeping collection of data for kind of broader, less focused purposes. But again, I'm really pleased to be here. Looking forward to the conversation.
And Sean Robbins, you're up.
Good morning, and thank you, Rachel, Ramsey, Sean. Great to be with you, and to all the folks on the line today. It's an honor to join along on this journey and this discussion. I'm Sean Robbins. I'm the Executive Vice President of the Blue Cross Blue Shield Association of America. And previous to that, actually, I was the president of Blue Shield of Idaho. So I have experience both urban and rural, now in Chicago in the role that I'm in today with the association, but previously leading a Blue plan on the ground in rural America. What I can tell you, and I'm so honored to do for the association, is represent 1 in 3 Americans who carry our card in their wallet every day. And we're in every zip code in America, much like Sean was talking about family physicians and primary care being located throughout our communities. The Blues are in every zip code in this country. So we have the unique honor and privilege and responsibility, I think importantly, to serve every corner, every person, no matter where you are, where you come from, what you look like. You deserve accessible, affordable care, and importantly, equitable outcomes in that care. And that's something we're using our platform of responsibility to leverage into the future at the Blue Cross Blue Shield Association and in our plans 35 of them located across the country, is to try to drive sharper focus on health equity, as Sean and both Ramsey mentioned. Earlier this year, for folks who may not be familiar, we launched a national health equity strategy. We took a bold look at what we needed to do as a voice within the healthcare system to try to move us collectively forward across the healthcare spectrum. And we've committed to try to reduce maternal health disparities by 50% over the next 5 years. Now, we know we can't do that alone. It takes a village, and it's going to take a lot of fellow travelers to move us in that direction. But it's unconscionable when you think about the fact that Black women are 3 times more likely to die from pregnancy-related complications than white women. And that in the last 2 years, even as Sean mentioned, during COVID-19, Latina women's complications have grown by 19% in just a 24-month period. These are 2 sharp data points that sort of exacerbate an underlying issue that we've had in the healthcare system for some time, and COVID-19 sort of sharpened our focus on it collectively, as you've heard Sean and Ramsey speak to. So we're trying to leverage our platform for good in this space. We have a long-term commitment to move the needle on it. And we think data, and to Sean's point, not just data for data's sake, but data for an outcome, for an end. We're awash in data. So how do we turn data into information that leads to insights that drive better healthcare outcomes for the entire system? So I'll simply end my introduction with, it's an honor to be with these folks on this call today. It's an honor to have this conversation, to continue to drive it. And I think a public and private partnership between government and the private sector is a really important place to start as we continue to build on this foundation. So I'm happy to be with you this morning.
All right, let's dive right in. Wanted to start out with a timely topic. We know that incomplete data, disparate data has been really a challenge in the pandemic as the country crafts its pandemic response on data. So Sean, I wanted to start out, sorry, Sean Martin, we have 2 Seans today. I wanted to start out asking about the challenges with the flow of data in terms of public health and vaccine data, and 1, kind of the state of that, and 2, is there anything the feds or state health groups are trying to do to essentially improve that?
Yeah, an interesting question. I'll try to be brief here. I mean, obviously there's an immense amount of improvement that can take place across the country, and some of it is just a consistent effort, you know, between local health departments, state health departments, state governments. I mean, there were states that did report, states that didn't report. The frequency of reporting really has been disruptive, I think, in truly understanding the impact on communities. So there's obviously an areas for improvement moving forward. I think the important thing is it didn't start with COVID. I mean, there was a disruption in not just vaccine reporting, but, you know, all kinds of healthcare data reporting on the public health side prior to COVID. It was, you know, a deteriorating practice in many community and states before the pandemic was ever imaginable. I think for physicians themselves, I would go back to my actionable data. I think, you know, there's the subset of information that is really needed at the point of care, especially in an environment like this, probably should be refined so that it's more widely available and pushed out versus this kind of, you know, aggressive effort that a lot of not just physicians, but hospitals and public health clinics and community health centers, et cetera, oftentimes had to go mine or search for data versus it being readily available in a uniquely reported manner and taxonomy so that they could understand what the data was. But a little bit of a rambling answer, Rachel, but I think there's lots of room for improvement. I think physicians and other clinics and care settings found their way through it, basically through kind of, you know, leaning into it more than it being readily available. But I think this is, for the country, an area that needs a lot of attention moving forward, just as we prepare for future pandemics, endemics, et cetera.
Mm-hmm. And off of that, Ramsey, from the consumer's perspective, what has the pandemic shown a light on that needs to be improved in terms of not just health data, but the broader public health infrastructure?
Sure. Well, I echo Sean's sentiment. There's so much work being done, but really it's not enough. Just from our field, you've got 80% of those experiencing tragic outcomes due to the pandemic being older adults themselves. And older adults have trusted community resources that they go to. Yet when we sort of step back and look at the public health approach to preparing for vaccine outreach administration, the Aging Services Network, which works closely in communities, we're talking about senior centers, area agencies on aging, councils on aging. These are organizations with deep, deep ties to those in the most vulnerable communities. They are trusted, trustworthy messengers. They have been on the front line serving people throughout the pandemic, providing access to food and housing, transportation, just a real lifeline around so many of the social determinants of health. Yet when those plans were crafted around vaccine education, outreach, and administration, often aging providers were not at the table because they are not a medical provider. Yet they're a provider of so many critical social services and supports that have implications for one's health and well-being. And these communities, they know their organizations, they know their communities, they know their consumers best. They know how to address some of these hesitancy issues because they have that deep level of insight and cultural responsiveness. Yet we haven't found a way to get them seated at the table in the public health planning. Sean Robbins mentioned the point about a really important need for a public and private sector collaboration. I would add nonprofits to that. It must be a three-sector, multi-sector type of collaboration where everyone brings their insights, their data, and their assets to bear so that we have a planful approach. So many of those aging service providers had the lists of the older adults themselves, but getting to the table to plug into that plan was a challenge. Thankfully, I know many today have found their way into the system, and I think of one example in Texas. WellMed Charitable Foundation does incredible work in Texas and Florida. They happen to have senior centers. And because those senior centers are affiliated with WellMed, they were able to quickly transition their senior center facilities, draw upon those vast lists of older adults that they have a great deal of trust and credibility with, and instantly set them up as vaccine administration sites. And because they were affiliated with WellMed Health, they were able to get their systems to talk to each other so the reports could go up to the states and ultimately to the feds. But that is a rarity where it needs to become the norm, where we have the Aging Services Network engaging with the clinical community, truly integrated, so we can build a bridge between the world of public health and medical interventions and community-based social services that are often so critical to the social determinants of health.
Just wanted to dive into the point that you made from Sean Martin and Sean Robbins, when both of your organizations are crafting how to do vaccine outreach, et cetera. What do you consider, what kind of different stakeholders do you talk to and bring to the table?
Pardon, Rachel, was that focused on NCOA or Sean?
Oh, I'm sorry. I think my computer froze for a second. Sorry, Betty. I was wondering when providers and insurers are crafting their infrastructure, what stakeholders do you bring to the table when you're trying to figure out things like reaching out to different vaccine campaigns and trying to get a massive effort like this going? So you can start with either Sean.
I'm happy to jump in. I think so. We it's a little bit of a funnel, for us at the national level. We really, as an organization, try to connect with anybody that has a shared mission and the ability to inform and empower our members to provide better care at the community level. I think as it funnels down to the community level, one of the, as I said in my opening comments, Rachel, our physicians tend to be members of the community. They're, we say they're usually on Main Street. So they tend to be very well connected to, organizations, aging organizations, and organizations that Ramsey represents in their community. And we typically don't need to connect them. They have those connections from their community infrastructures or kind of ecosystems that are already in place. I think what COVID taught us is when you take a step above kind of the county or community level and you look at kind of regions and states, that's where the collaboration really, I think, broke down and could be improved. There wasn't regional collaborations like you might see in other efforts, unless there was some type of aggregator that took place, you know, an insurer or a major health system or something like that, that was kind of bringing people together and disseminating information. But in particularly rural areas, the regional alignment became very challenging, both to get information out and to share information with each other about what was happening.
Yeah, you know, picking up on Sean's point, I'm going to apologize. I lost network connectivity. So now I'm doing it from my iPad and you have this very awkward angle for me, but I'm going to do my best, Rachel.
The
Sean,
virtual world.
welcome, right? Speaking of technology. In any event, picking up on Sean's point, I mean, insurers in particular, and I think Blue Cross Blue Shield plans were in a unique position being an aggregator. And I think that's a good word of outreach and information. But we often found, especially during COVID-19, that the data itself and the information could be quite choppy and disaggregated. And so if we had better access, particularly to race, ethnicity, and language data in a safe and respecting the privacy, of course, of the individuals that we serve, we're actually going to be in a better position to outreach to underserved communities and people who are often overlooked or who have poor access in the first place. That data would give us sort of a running start, if you will, in order to reach out and try to support those individuals, those families, and those communities. And that could be both socioeconomic and socioeconomic profiles of health indicators, but it could also be simple as urban and rural. And looking at rural access and primary care physicians and vaccine access, or it could be on food deserts, transportation linkages, or lack of transportation linkages for that matter. So I think it underscores the point that the more robust data we're able to build, the more standardized data sets we're able to build as a country between private and public sector, the stronger position we're going to be in the future in order to serve those populations who may not necessarily have the direct access to the healthcare system that a lot of us enjoy today. And that's part of that commitment and push by all of us towards equity.
And off of that, Sean Robbins, there's a lot of pressure, and you saw it from members of Congress in the first few months of the pandemic in terms of trying to get better data on coronavirus cases and deaths in terms of race and ethnicity. And as you mentioned, so I'm wondering are there any proposals from Congress or the Biden administration that you've seen? And is there anything kind of concrete that your organization is asking for, pushing for?
Yeah, it's a great question. You know, there's a lot going through Congress right now, Rachel, as you report on every single day in Health 202. I would say one that's interesting is our Momnibus package. And the Momnibus package is a collection, I say our collectively as a country, but it's the good work of congressmen and women on the Hill packaging together a number of policy solutions to try to reduce the maternal health disparities you heard me speak about at the beginning of this call. There's a lot of elements of that package that we are very supportive of. And one of them in particular and applicable to this call is the data component and building an improved data collection process and quality measures that would help us all better understand the causes of the maternal health crisis in the first place in the US and be an antecedent, if you will, to further inform and address solutions that we can all implement to try to get after that problem. Now, there's a lot of other pieces of that Momnibus package that's part of what's moving through Congress now besides the data component. I don't want to overemphasize just the data piece because there's a lot of other important pieces in that package. But Rachel, I would say BCBSA and the Blues are all in on trying to help that policy package move through Congress right now for a lot of reasons that are tied to our national health equity strategy. But also because it's a step towards building that more robust, standardized data set that we need.
And as we're talking about this data, this kind of, as you said, data set here. Just wanted to step back real quick. Ramsey, can you talk to us a little bit about the collection of social determinants of health data and kind of what it looks like now, and if there are things you think that need to be done to it to improve the collection of this data?
Thanks, Rachel. We really believe data must be holistic and consumer-centered. And we're strong supporters at the National Council on Aging of a holistic approach to defining and collecting the data. Where consumers live, learn, earn, and play clearly affects their health and their quality of life, their risks, and ultimately their outcomes. When we look at end of life, the disparities are tremendous, with the sort of benchmarks of the bookends of white women versus African-American men. We're looking at 10, 15 years variation in life expectancy. And it's largely due to these social determinants that are not yet baked into our health IT systems. Today, often the systems are built in silos based on what healthcare payers want or need to know, reasonably so, but not necessarily in the true consumer experience. And moreover, while data collection is key, its standardization, its utilization are even more important. And so I think there are some examples out there where we can begin to look at how US Census and how others have been able to standardize that data, look at various components, race, ethnicity, language, gender, other key demographics, to better identify the root cause of that cumulative disadvantage that plays out in old age, shortening life expectancy. But first, we just need some standard demographics. They need to be written broadly and capture a wide ranges of responses. So then we can begin to examine where we need to build systems in support of different factors. So for example, just adding a basic other box can sometimes be helpful to collect what other may mean for individuals and then identify new ways to collect data regarding respondents. It also allows respondents to feel seen and included. And it captures a new story that can open up a whole conversation about the themes that are being identified. It's not until we really garner an understanding of the inequities in healthcare and the delivery of it that we can collectively build the solutions to address the systemic failures. And so we need to be thoughtful about this process and really engage, again, some of those community-based organizations that are closest to these populations that have often been left behind and gather their insights as well.
I'd be interested to hear first from Sean Robbins and then Sean Martin if there are standardized collections of data here, kind of what it looks like on both of your ends.
Sean Martin, you want to take that first?
Sure, I'd be happy to. So I think there is some standardization of data collection. I mean, obviously CMS, HHS, and other agencies have published kind of, I think, a standardized 5, racial groups, 2 primary ethnicities in the kind of data collection infrastructure or regulatory structure. I think, as Ramsey said, I think we need to start thinking about moving beyond that, particularly, on identity, of broader racial groups versus the 5. Sexual orientation, gender identity, maybe language spoken. I think if we truly want to connect and understand the communities in which all of us serve and the patients we're seeking to help and benefit, it's going to be important to think about data, in a more granular way, potentially. And I say that going back to my opening comment about, we don't want to just flood the healthcare system with data that's not actionable, but I think this is one area where data is actionable, and it does actually help align services and resources with patients groups or communities in a more meaningful way. I think the other thing is just even though it's 2021 approaching 2022, just standard boxes of input and language from one medical record to the other and how that gets transferred still is a real challenge. And the transfer of information between people oftentimes is just simply broken down because of the different types of styles or input boxes or number of characters, et cetera, that, can be used becomes prohibitive, quite honestly. Just to put it that way, it becomes prohibitive, and that's a problem.
Yeah, building off that, look, there have been a number of efforts over the years to try to standardize, and there have been good positive steps to try to standardize that data. But there really isn't any true industry standard today.
Mm-hmm.
And there are fits and starts here and there, and great work, particularly on interoperability, and trying to get, say, medical records to talk to payer systems and so forth, so that the consumer's healthcare information, by the way, it's their healthcare information. It's not the system's information. It's not the payers. It's not the providers. It should be the person's healthcare data, and it should move and be portable with them. But there hasn't really been an industry standard implemented to date. And I think this is if you will, a call to action for all of us across the spectrum, no matter which part of it you're in. And Ramsey, to your earlier point, whether you're a nonprofit, you're a provider or a physician on the ground, you're a hospital system, you're a payer, all of us need to, really continue to force industry and government to come together, have a call to action to create common industry standards. And this is a place, candidly, where I think the private sector can lead and continue to lead as it has. The technology moves fast, changes fast, evolves quickly. And I think having sort of a coalition of the willing around standards is incredibly important for us to continue to adapt and move to that quickly. There's a key thing I want to say in that, which is also trust and privacy, right? The reality is the system will work under those types of standards if there continues to be deep consumer trust that the data is protected and it's used ethically. And so privacy and alignment of even third-party apps and ecosystems with HIPAA compliance and ensuring that those standards also emphasize trust and privacy are going to be really important as we come together and drive on that.
Sean, you mentioned actionable data several times, and I'm wondering if there are any ways that providers are particularly using the data that they get to address disparities. What does kind of taking action based on data look like?
Yeah, I think I agree with Sean and Ramsey. I think this is to be defined, and I think it means something different to everyone in the healthcare ecosystem, or kind of across the spectrum of healthcare. For our members, I think we are closer to the community. I think oftentimes our members have a deeper understanding because of the connectivity with their patients and their communities that they serve. But actionable data comes into play, and I'll just put a finer point on it. In COVID, you may only have one opportunity to vaccinate an individual. And if the physician or the healthcare team or the social worker in that office or whomever, can't determine the vaccination status of that individual and they leave that office, there was a missed opportunity there. And when I talk about actionable data, it's just making sure, the data that they need to provide care at that point in time is available to them. On social determinants, I think, I think this is, to Sean's point, a place where there needs to be a commitment from partners and organizations across the healthcare industry to try to identify some standards so that there can be commonality in data collection and understanding of what that data means and how it applies to the healthcare system. I don't know that I have an answer. I think all of us would put this in the must solve column, for our organizations and for the people we represent, but I don't know that we're to that point in the policy debate yet.
So Rachel, can I pick up on a point that Sean made that I think is really important?
Yes, please.
I think we do need, as a collective, a definition of what we mean by health equity. Because we all have different definitions. And so to that point about looking more broadly, multi-sectoral collaboration, we all need to come together. And that includes collaborating with community-based organizations and consumers and understanding why they feel left out of the conversation to date and how we need to collectively define health equity, what it means to them to be included. And then we need to think about making sure we've set up the systems, the data referrals, the data transfers, so that we can address the broader range of social determinants of health and make sure that network that's available to provide those supportive services, often community-based organizations, they have the capacity to meet the demand. Because I think when we truly center on equity, that does mean looking at the whole person and being consumer-centered. And it means going beyond just the medical intervention, but also to look at the social determinants of health. And we need to ensure that we have capacity and access and availability to the range of social needs, supports that individuals will need to get on track to achieve those equity outcomes.
Also, a really good question for your next panel. They might be better positioned to answer that for us.
We do have a question from the audience that I wanted to go to, which is, how is data bias being considered as you collect data?
It's a great question. You know, I'm happy to try to, by the way, it's a complex answer and it's a complex question with a lot of layers. And it's a great question at the same time, because anybody who's worked with data long enough knows you can make data sort of say what you want it to say at times. And so it's really important that the data collection process be robust, verifiable. Oftentimes data itself is a collection of those who have access to the data collection process. And so it naturally can leave people out. So I think, and we talk about this in our organization quite a bit, particularly around even our unrelated but also related work on diversity, equity, and inclusion. There's a key part of DE&I, and it's inclusion. And inclusion is just as important on our data collection processes to figure out who isn't being asked, who isn't being included in that process, whose voice isn't involved, as much as what is the data we are collecting telling us. And I think it's going to be a continued process of questioning, is this actually representative of the people we serve? Or is this representative of a collection of people who have access and we have access to? And so we're continuing to challenge ourselves within the Blues about who we go out, how we collect that data. And candidly, I think it's an area where we could continue to use industry standardization around the ethical use and framework around the appropriate use of that data. So again, I think it's a maybe even connecting to Ramsey and Sean's earlier point about a common definition of what is health equity to us and how do we all solve for that common definition. I think there can be some industry standardization around the common definition of what does a complete, full, and robust data set actually look like to help us drive towards solutions. And that will be a work in progress. I don't think we will be perfect. I don't think the system will be perfect, but I think being honest and vulnerable and saying we are continuing to learn how to do it is really important part of the process to actually driving towards equitable outcomes.
Mm-hmm. I would just add, there's a lot of data that is collected by memory or maybe captured in some unofficial way in primary care settings related to food security, housing security, maybe transportation availability, compliance at the end of the month because of economic insecurity. So maybe they fall out of compliance with pharmaceutical intervention or therapy because of food insecurity or housing insecurity. And I mean, there's just all of that information is not necessarily being collected in a formalized way, but it's being collected in an informal way at practices that are really helping them, drive towards providing better care. And I'm pleased you're starting to see insurers and, large health systems and public health and community organizations begin to try to find a way to capture that information to provide better care to their communities. But there's a lot of unofficial data out there being collected in various ways.
And I'd agree, that is the challenge. It's unofficial, it's not yet talking to each other, the data sets aren't talking to each other. And we share the concern that the bias comes from those that are not in the system at all, right? So those that don't have access to
oh no, I think Ramsey froze unless it's just my.
No, I think she did, Rachel.
Okay,
You did
okay,
great.
confirmed. All right, well, while she comes back, we just have like 2 or 3 minutes left. So very quickly, wanted to just do a round robin and end on kind of the future note to see what should be done in the future to better bake health equity into the health IT structure, into the medical industry structure, into the nonprofit sector. So I think Rams might be back, but
I am. My apologies.
Oh, no problem. We're just going to end on a quick future note. So asking what is best to be done to bake health equity into the health IT structure from the industry or the nonprofit sector. So Ramsey, if I'll leave it to you to start out.
Wonderful. Well, at NCOA, we often say your health is your wealth. Your wealth often determines your health. And so really getting this right is so critical. If we're going to maximize this moment and really drive an agenda forward that ensures health equity for all, we do believe we need to take a step back, be intentional, and have a collective conversation about what we mean by health equity so that we can really, really address moving forward what has left so many behind. And that especially is critical when it comes to incredible technology breakthroughs. So telehealth, for instance, just a phenomenal rapid adoption due to the pandemic. Unfortunately, with the digital divide for certain populations, without the access to the hardware, the software, the digital literacy, it can leave people behind and only exacerbate disparities if we are not intentional. So I hold up the telehealth example as one that we need to learn from, that we need to step back, think about the unintended consequences, be more deliberate and mindful about ensuring health equity outcomes for all, and addressing the full range of dimensions to ensure that health equity and those equitable outcomes so that everyone can enjoy the gift of quality of years and quantity of years.
Rachel's on mute.
Oh no, we just have 1 minute left. So Sean Martin and Sean Robbins, if you each have a 30-second lightning round answer, and
two things for me.
Go to the next panel.
Standardize race, ethnicity, gender identity, and then use automation to provide all other information that we can possibly provide or gather to empower practices.
Thanks, Sean. That was good. Hey, look, you heard me say it. We have got to drive industry standards that respect trust, privacy, and to Ramsey's point, are inclusive of the entire population that we serve. And so you're going to hear us continue to drive on this. We think there's a call to action here around that work and a coalition and alignment of the groups that are on this call and other groups. Look, at the end of the day, we've been fighting for a long time to make access the hallmark of our healthcare system. But as we've achieved access, we've really got to drive now on affordability of that system to begin with, and the equity within that system. It's no good driving access to a system that's unaffordable and unequitable in its outcomes, and that's where our focus lies for the future.
And we're out of time. Thanks everybody for joining us this morning.
Thank you.
Thank you, Rachel.
Thanks, Rachel.
All right, thank you so much, Rachel, and thank you to Ramsey, Sean, and Sean for an excellent panel. I think there's a lot of food for thought there, and certainly some themes that we will hear most likely reiterated throughout the day. So I will turn our next session, which is Perspectives from Congress on Health and Data Equity. We have here Rachel Dolan, and also I think connecting still is Sarah Burkmeyer-Bell. There she is. I will just briefly tell you a little bit about their names and titles, and then I'll turn it over to them. Rachel and Sarah, if you want to just introduce yourself and give a little bit of information about 2 to 3 minutes on your role in supporting Congress on some of these issues, and then we'll turn it over to Q&A. So we have Rachel Dolan. She is a professional staff member on the House Ways and Means Committee, the Health Subcommittee, and then Sarah Burkmeyer-Bell, who is a policy advisor to Senator Dan Sullivan of Alaska. Rachel, how about I turn it over to you to just say a little bit about the Ways and Means Committee and sort of your interests related to health equity and public health.
Sure. Well, first of all, thank you for having me here today. I just want to start with a brief caveat just by saying that, my comments, the comments that I provide today are mine alone and not a reflection on, the positions of the Ways and Means Committee or the chairman of the Ways and Means Committee, Rick Wiggin. So as you said, I'm a professional staff member on the Ways and Means Committee. I work on particularly Medicare issues as they pertain to Medicare Parts A and B, and also have been leading the health equity work that we've been doing on that committee through the health subcommittee with my colleague Ariel Richardson, who is also leading the committee's racial equity initiative. So I'll just back up here for those of you who are not as familiar with the Ways and Means Committee. We have jurisdiction over the tax code and Medicare by virtue of the tax code, all 4 parts of Medicare, jurisdiction over the Affordable Care Act programs by virtue of the tax code. And we also, other subcommittees oversee Social Security, trade issues, worker and family support programs, including, paid leave, child care, and we also have an oversight subcommittee. So we have a lot of folks with varying expertise across the domestic care continuum and also way beyond that. But my job, I work for the health subcommittee on behalf of the chairman. I'll speak a little bit to the health equity issues that we've been undertaking maybe a little bit later on in the program and turn it over to Sarah.
Great. Well, thank you guys so much for allowing me to speak. I am thrilled to be here. Same caveat, my views are my own and not necessarily a reflection of my boss. But I know that it's a topic that I'm really excited to talk about. I have a little bit of a different background than I think most Hill staffers have, in that I started off the Hill. I was a social worker and I worked with men coming out of jail that had addictions, particularly with working with men that had addictions. I helped my clinic transition from the DSM-4 to the DSM-5. So I have a lot of hands-on healthcare and a hospital system experience. And then I've used that experience while on the Hill to advance some of the policies on how we can make healthcare more patient-centered, how we can focus on things that are important to the patient, as well as how we pay for these things at the federal level and the role of government. So today's discussion is something I'm really excited to talk about and really excited to participate in. So I started on the Hill with the Senate Finance Committee. I was a fellow with them for a while. And then I worked for Senator Rob Portman on some fantastic bills. I worked on the Understand Act, as well as some other social determinants of health pieces. And now I'm working for Senator Sullivan.
Great. We are so pleased to have both of you. I think with that introduction and sort of framing, we will just go ahead and dive right into our questions. So Rachel, maybe let's starting with you. So with the pandemic, health equity has been top of mind. We heard about it from the CEOs this morning. We'll be talking more about it throughout the day. Congress is also considering this and prioritizing it as a key area to address. How are you and your committee and your members thinking about health equity, and what are some of the policy solutions that are before the committee?
So I'll just take a step back and go even before the pandemic, because this is something that our committee's been working on for a long time now. In 2019, Chairman Neal, along with Ranking Member Brady, established the Rural and Underserved Communities Health Task Force, bipartisan task force, looking at sort of the intersecting issues related to rural and underserved, other underserved populations. That work led to a report that we put out last July called Left Out: Barriers to Health Equity for Rural and Underserved Communities. That was based on an RFI that we put out to a number of stakeholders. I think we got in excess of 200 or so responses asking what are the barriers that we should be considering as a committee related to health equity. And I would just point you all to that report if you want to know a little bit more about kind of our analysis and where we came from that. But that was a launching point for some of the other work that the committee has been taking on in this area and in the 117th Congress. I should also note in the 116th Congress, we had several hearings related to health equity issues, the role of gun violence in public health, the maternal mortality and morbidity crisis sweeping the country, issues around aging and how they impact certain populations, more so than others based on resources and those sorts of conversations. At the beginning of this year, the Democrats on our committee put out a committee report and framework sort of spin-off on what we came up with in this Left Out report called Something Must Change: Inequities in U.S. Policy and Society, and an accompanying framework, legislative framework called A Bold Vision for a Legislative Path Toward Health and Economic Equity. And in those reports, we actually went beyond health equity to look at both health and economic equity across the committee's jurisdiction, which is why I started with that, to say, what are the biggest issues that our nation is facing in these areas, and what is our role as a committee in Congress to addressing these issues? You started the question, broadly about health equity, and what I would say to that is, in our view and the chairman's view, health equity is a lens through which to look at policy and address issues. It's not an individual policy. You're not going to fix health equity with one policy. It's a cross-cutting issue, and it is a way of looking at our specific policies and how they might impact some populations in some ways and others in other potentially detrimental ways. And so the idea here is to make sure that we are evaluating every policy that we put forward in terms of how it impacts equity or exacerbates inequitable distribution of resources.
Great, thanks, Rachel. And Sarah, as your boss is thinking about health equity, I know he has been active in particular on social determinants of health and data related to social determinants of health. So how does your office think about health equity, and what role does social determinants play in that? I think you're on mute, Sarah.
Sorry about that. So I think, starting at the beginning of the question of, essentially, I think what you're asking is, how do we think that the role of government fits into social determinants and health equity? And I think that that's a really great question. I think that it starts with the value it brings in targeting how we can best use our funds and targeting how we can best fill in coverage gaps. And so when we're talking about social determinants and we're talking about how technology and data can play a role in advancing health equity, we're talking about how can we better target our funds, how can we show where the gaps in the coverage are, what programs have been successful. There's a lot of programs that we have in the United States. Some of them are phenomenal and some of them are less phenomenal. And so, we used to have a limited federal government funding stream. And so how do we target those funds on the programs that are reaching the most people, reaching the people that are falling through the cracks? And so if we don't know who the people that are falling through the cracks are, we don't know how to reach them. And so data has a huge role in health equity. Technology has a big role in health equity, and making sure that wherever the federal government is involved, we're placing incentives. And so we want to be aware of the incentives that we are creating and how we can make sure that we're capturing everybody and that there aren't people left out of the gaps. And I do think sometimes that Congress can be too obsessed with data. I just think that it's something that we probably should just mention, not to say that we shouldn't be advancing data and we shouldn't be trying to get more data, but I just think sometimes we've got to consider how our federal policies affect the people that are on the ground, the social workers like myself, who have to fill out the paperwork, who have to help with the referrals. I think that that's just something that is worth mentioning. It shouldn't stop us from continuing to seek data and continuing to advance those efforts, but it is something that's worth mentioning.
Great. So one part of the whole conversation around data and technology and advancing health equity through data and technology is, collecting that data on social determinants of health, certainly, but also demographic data such as race, ethnicity, and language data. So how is Congress approaching this, and where do you think that there is room for the federal government to take action, just as we think about some of that data that can be helpful in identifying disparities or targeting public health interventions, but that might be, historically a little bit more sensitive as far as, people making sure that they are getting access to care when they need it, and maybe just a little bit more sensitive than the standard sort of demographic data.
I guess I can start. So thank you for that question. I mean, I think the key point here is that data is now ubiquitous, and it is going to drive a lot of decision making. And the important point here is that, we need to acknowledge that not all data is unbiased, and that not everybody collecting data is operating for good. And so data has the potential to help us track and understand inequities and, refine our policies and address needs in the way that Sarah was talking about, targeting those needs. It also has the potential to exacerbate disparities. And so we need to be very careful about how we are thinking about these issues. And at the same time, I would also say, as data becomes ubiquitous, we also need to give the people the tools to understand that data, right? So health literacy, data literacy, or numeracy are very important aspects of ensuring that, the public, as these data are being collected, understands what it's being used for, understands how to interpret it, so that we don't just have a bunch of data out there and people using it for malicious means, right? So we need to give people the tools to be able to understand and interpret those data in an effective way. I would also say, something that we on the committee have been thinking about is, for example, clinical decision support tools. The chairman put out a request for information to a number of medical societies last year, and we've been analyzing those results, and we'll have a forthcoming report that basically pulled off of the New England Journal of Medicine article that came out last summer, which pointed to the bias in clinical decision tools, right? For example, you can be, two people that look exactly the same, but have different races come out, have different risk factors based on some of these clinical decision support tools. And so the notion here, and, I think our role as Congress is to shine a light and ask important questions about these things. Sometimes there's a policy intervention and sometimes there's not, but, we need to be having these important conversations about the role of data. It can be used for incredible good, and it also can be used for issues, right? It can exacerbate these disparities. And so that was sort of one of the, things that we've been looking at, is like, how can we make sure that the data underlying the decision tools that we have out there is being used for good.
And I think too, just building off of that, it's very clear that healthcare is extremely siloed. The government is siloed overall, but healthcare is also extremely siloed. And so you have like one department that is getting data that says one thing, and one department that's getting data from another, because their questions are a little bit changed, or their the outcomes that they're trying to measure are a little bit different. And so they come up with different information. And so I think that is a really big part of this is, healthcare is so siloed, and the data that we're getting is so siloed. It's not necessarily whole picture. It's not necessarily looking at the whole person. It's usually just trying to measure one specific thing. And so I think one area that I think data could get better is if we could view whole picture information, as opposed to just, here is, yes, this person has diabetes, and yes, this person is more likely because of other outcomes to have, I don't know, coronavirus or something. So I think just whole picture, like data just doesn't always take in the whole picture. And also I think that one thing that also is worth mentioning is that I think when we're considering data, I don't know that it is fully the federal government's role to be involved in this fully. I think a big part of it is how do we incentivize communities to come together to meet the needs in their communities, as opposed to just how can the federal government fix this problem. And I don't think that's the answer for everything, obviously, but I think that when we have more data, we know what resources are in the community, and we know where the gaps are that are in the community that the federal government can then come in and fill. But I do think the question should first be, what can the community do on its own?
And if I could just add one additional thing to that, I think that that's a really good point about the silos and kind of the challenges that we have painting the full picture. I mean, even just taking a step back from that, you talk about race and ethnicity data. I think, before we get to even the point of collecting data on social determinants of health, we need to ask the question, like, is our race and ethnicity data like accurate? And like, I think in a lot of federal databases that there's a question about that, right? So how are these data being collected? Are they being collected based on self-reported information? Are they being, transferred from another form that somebody filled out when they enrolled in a certain program? I think, I would just speak to the Medicare side of things. We have problems on the Medicare claim side in terms of the data that is available for estimating impacts on certain racial and ethnic groups. And I think that as a starting point, we need to make sure that those data are really ironclad to be able to use them in a way that is impactful in developing interventions.
Great, that is a great point. I know we just have a few minutes, so I want to make sure we do sort of maybe end here on the public health side of things, because today's session is focused on both equity and public health. Sometimes they're intertwined, sometimes they're separate, of course, but there has been a lot of discussion about technology in particular on the public health side of things, and what infrastructure we need to have in place to support better crisis response in the future, or even just better routine public health response in the future. So I think, that one of the lessons of the pandemic has been that the public health infrastructure needs to be strengthened. And I'm just wondering how Congress is thinking about the role of technology in strengthening that infrastructure and what you would expect, going forward over the next weeks and months.
Well, I'm happy to start this. I can tell you that my favorite bill in Congress is the Link Act, which is a bill that basically incentivizes communities to come together and states to come together and say, all right, let's bridge the gap between social services and healthcare. We all know that the emergency room is the biggest entry point for a lot of people with a lot of social needs. And so that might not necessarily be the best entry point. So how can we get our healthcare sector to work better with our social services sector? Because a lot of doctors would love to be able to make these referrals, but they don't know how. And so, the Link Act is a bill that comes that allows states to come together to create their own system where our healthcare system and social services system can work together to make referrals and to build to collect data so that we actually know, okay, look, this part of the state is meeting food insecurity really well, but we don't have these resources over here. And so that, again, we can target our funds better to know where the needs are so that we can bridge those gaps. And so I could talk all day about it, but I'll just say that that's my favorite bill. I think that it's a great way to build public health infrastructure, because a lot of the resources, not all of the resources are there, but a lot of the resources are there, and it just people need to come together to meet these needs instead of, oh, there's a food insecurity in my community, I'm going to just open my own food bank. Well, there might be one down the street. So let's work together to identify where the resources are and what the resources are, to pinpoint where we need to continue to build, but to meet those needs.
Thanks, Sarah. Rachel, thoughts?
You asked the question about public health, and I think I'll turn it on its head and just say that if COVID has taught us anything, it's that we can't have our public health system working in a silo, right? It needs to connect with the health financing system, state systems. I mean, going back to this issue about data, we could clearly see where the gaps were between our public health system and our health financing system, right? The claim form, for example, has that has information about the patient and who that patient is, but it doesn't talk to the public health system. And so we aren't able to sort of track those important outcomes. So I think that, this is not just about investing in our public health system. It is investing in the linkages between our health system and the rest, our public health system and the rest of the health system, including the health financing system, which my committee has jurisdiction over. And so that's sort of the way we need to be thinking about this, particularly if we're talking about addressing health equity issues, which, going back to how I started this conversation, it's a lens through which we look at policy interventions. And so, it is cross-cutting and needs to be dealt with in a broader scale than just looking at one system versus another system.
Great. Well, clearly there is no shortage of tricky issues to resolve here, but also very important issues as we think about how our healthcare system works going forward. So I want to thank both Sarah and Rachel for joining us today. It is the work you're doing is truly very important, and we look forward to working with you on these important issues going forward. So thank you for taking some time out of your day to be here with us today.
Thanks for having us.
Yeah, thanks so much.
Great. And with that, I will transition to our first panels. So we are mostly on schedule for today, just a few minutes over, and we will try to keep this train running like clockwork today to make sure that we finish right on time. This first panel here is advancing health equity through health data and infrastructure. Again, a topic that we've talked about a lot today, but I think that these panelists will bring some new and detailed insights into this issue. So our moderator today, I will turn it over to her briefly. Our moderator is Dr. Lucienne Eide, Chief Executive Officer of Remedy and the co-chair of the Health Equity and Access Leadership Coalition. She will be joined today by our panelists, Dr. Maria Caban Elizondo, hopefully I'm pronouncing that right, Director of Health Information Management Services at UCLA Health System, Elliot Fishman, Senior Director of Health Policy at Families USA, Joy Lewis, Senior Vice President of Health Equity Strategies and Executive Director of the Institute for Diversity and Health Equity at the American Hospital Association, and then Dr. Lisa Schaffner, Vice President of Care Analytics at Highmark. I will turn it over now to Lucy, but I did want to point out that bios, more complete, longer, formal bios are posted on the website. So if you want to know anything else about our speakers here today, you can find the information there. So go ahead, I turn it on over to you.
Thank you, Kristen. Thank you everybody for being here today. So just to briefly introduce myself, I'm Lucienne Eide. I'm the founder and CEO of Remedy. We're a health IT company with a clinical management platform that focuses primarily on chronic disease management. And through that lens, we certainly have a commitment to building technology that's accessible to assist in the care of all patients, especially medically underserved populations who tend to over-index in these chronic diseases and have worse outcomes. I've also had the pleasure over the past year of serving as the co-chair of the Health Equity and Access Leadership Coalition, which is a joint initiative of the Consumer Technology Association and the Connected Health Initiative, and represents over Dr. Schaffner, would you like to go next?
Yes, good timing. The audio had dropped off for a moment there. Could you please repeat your question for me?
I was just asking if you'd like to introduce yourself.
I would be glad to. Thank you. First, I'd like to thank you all for the opportunity to be here today and be part of such an esteemed panel. As I was announced earlier, I'm Dr. Lisa Schaffner. I'm Vice President of what is called Care Analytics at Highmark Health. Highmark Health, for those who are not familiar, is an integrated delivery and financing system based in Pittsburgh, Pennsylvania. We are a member of the Blue Cross Blue Shield Association through our payer organization, Highmark Incorporated, which spans the Pennsylvania, West Virginia, and Delaware markets. And we also are the owner of a integrated care delivery system, Allegheny Health Network, based here in the Pittsburgh metro area. By background, I'm a health services researcher. I have my doctorate in healthcare policy and administration from the Johns Hopkins Bloomberg School of Public Health. And in my role at Highmark, I am accountable for embedding health and healthcare outcomes into all that we do, including social determinants of health. So again, great to be here with all of you today.
Thank you. Joy Lewis, would you like to introduce yourself?
Sure, happy to do so. And thanks again for this invitation and the opportunity to share this panel with my fellow colleagues here. I'm Joy Lewis. I'm the Senior Vice President of Health Equity Strategies at the American Hospital Association. I also am the executive director of our Institute for Diversity and Health Equity. And I know that's a mouthful. The association last year, well, as you know, the association represents almost 5,000 hospitals across the country and other professional medical groups. and last year, we announced an organizational realignment to reflect the association's increasing focus on health equity. And this included the creation of my role. So this is a brand new role that I transitioned into earlier this year. And a decision was made at that time to also integrate the institute that I mentioned earlier, which historically for over 2 decades had been an affiliate of the AHA, a separate legal entity. And now that it's been fully brought into the AHA family, we're able to maximize the assets and really leverage the breadth and depth of the AHA to advance health equity work. And so health equity is one of the association's 3 strategic priorities alongside workforce and behavioral health. And I'll just say that our collective experience over the past year plus dealing with the fluctuating pandemic and its disproportionate impact on Black and Brown and other communities of color, alongside the events of last summer following the death of George Floyd and this renewed call, if you will, for social and racial justice, has led to our members really chomping at the bit for actionable solutions. What can they do to mobilize around dismantling structural racism and really building up more diverse and inclusive workplaces and really serving the communities in a different way. So I will say that our members see this work, not just, it's an imperative for them to do something to disrupt the status quo. And really, we're talking about sustained long-term change here. And in my mind, this imperative is not just moral, it's really the way that our hospitals will be positioned to take care of the full person and to really serve the populations in a much more value-based environment and thinking much more from a pop health perspective.
Thank you very much. Dr. Caban Elizondo.
Good morning. Thank you so much. It's such a pleasure to be here. I'm Maria Caban Elizondo. I'm the Director of Health Information Management for UCLA Health System, and I am also the board member on the board of directors for the American Health Information Management Association, who is one of the affiliates that is sponsoring this event. So I'm really excited to be here. I think, you know, one of the things that is really not just been focused because of COVID, but even leading up to this has really been, as we've all discussed this morning, the identification of these social determinants of health and health equity. And by extension, some of the work that I'm doing with AHIMA is also health literacy, finding ways to bridge those gaps. So I lead a team at UCLA Health that works to support patient care and patients' right of access to their health information. But that's just one step. We can provide access, but do the patients understand what they're reading, how they can really be the pilots of their healthcare? And that is the most important thing in terms of our mission and our vision to provide healthcare to the patients we serve. You know, we're fortunate at UCLA Health to be located in a geographic area of Los Angeles in which our campus and clinics border both high income and low income communities. And we've come to understand that health inequities span income, education, racial and ethnic boundaries, that there is no clear understanding of these limitations when it comes to helping a patient who maybe lives in a mansion in Beverly Hills understand their record versus someone who lives in a different community. They each have particular considerations. And earlier at the CEO Roundtable, there was a lot of really good discussion about how we need to ensure that all of these sectors are represented in these discussions. Gender, ethnicity, race, class, aging, all of it. And so we really work hard to make sure that those sectors are incorporated into discussions about how we implement policy and systems in the work that we do. I think one of the biggest things that has occurred in the last few years that I'm really proud of is the advocacy work that the American Health Information Management Association has done around health equity and health literacy with respect to how we can identify in a more granular way those specific health identifiers and those gender identifiers and ethnic identifiers. So I'm really excited to be part of the discussion, and I appreciate the time.
Thank you so much. And Dr. Fishman?
Thank you. I'm Elliot Fishman from Families USA, where I'm the policy director. And I wanted to specifically thank the Roundtable, not just for inviting Families USA to participate, but for focusing the conversation today on health equity. And I think already you can hear from the introductions of my fellow panelists how much the spotlight has moved in the health policy world to racial justice issues in a way that is long overdue. And I'm personally just very encouraged hearing the introductions of my fellow panelists, already, and looking forward to hearing more from them. As to Families USA, we do a lot of work on health equity. We are a national and state active at the national and state level. We're located in Washington, D.C., a consumer advocacy organization focused primarily on healthcare issues. And as for me, I run the policy department at Families USA and have been there since 2017. Before then, I worked at CMS, focused on Medicaid. And I am going to cut it off there so we can get into some meaty questions with Lucia.
Thank you so much. And what a fantastic panel. Thank you all for those introductions. And we have a great group with a lot to share in a limited period of time. So we will get going, and I'll ask all of you to try to be brief and concise so that we can get everybody's perspective across these important topics. As has been covered already this morning, we have this unique opportunity at this point in time, thanks to the grand natural experiment of COVID, that we have the public attention on public health as a sort of dinner table conversation, as well as, health equity and social justice. And so I think that creates a unique opportunity for change at this moment in time. And, I want to sort of move forward and maybe not repeat some topics that were covered earlier. So given, that we have the attention, right, we have the floor to talk about this, if each of you could maybe comment on what your organization has been doing, and maybe jumping to the specific question of like, collecting this data is tricky, right? Collecting data from individuals about race, ethnicity, language, social determinants, and sort of what is your organization doing, and what are some of the particular challenges that you have had to address? Because if we don't have the data, we then can't act on the data. So the first step here is collecting the data, and I would love to hear from each of you your experiences there.
So I'll just bring the national lens, as since we're one layer removed from direct practice as the association. We recognize that in order to transform or lead transformation in the field, we needed to start by building out our own internal capacity and readiness to lead the work. And so we are in the midst, I would say, of an institutional culture shift. We've essentially moved from talking about issues to really systematically prioritizing them. inside the AHA. And so earlier this year, the AHA issued a statement calling out racism as a public health issue, really just further demonstrating our commitment to this work and setting the tone for the field. Because ultimately, if we are to achieve our vision of a society where all individuals reach their highest potential for health, we must challenge our members to address the drivers and the root causes of health inequities. And I don't think the architects of that vision statement for the AHA, I don't think they were actually thinking about health equity when they wrote it. But it turns out that in essence, that's exactly what that means. And so through the Institute for Diversity and Health Equity, which is the AHA's vehicle for really pushing out information and evidence and knowledge and the resources and tools to guide the field in this work, we were awarded a grant from the Robert Wood Johnson Foundation in December of 2019. And with those funds, we are actively in the process right now of developing an equity roadmap for the field. It is in the pilot stage. It is a framework to guide our members to really chart their individual course, because we know, again, with 5,000 members, they're all in different places on their equity journey. And so it's really helping our members to transform their practices, their policies, building the vision, building the strategy, building the structure, ensuring that the leadership is on board. And then again, those tactical capacity, the how-tos, the toolkits. How do you actually partner with communities to address factors that will affect equitable patient outcomes? And so at the core of this roadmap is the Health Equity Transformation Assessment. And it is a performance-based assessment where our members are able to identify those key performance indicators and their activities and associated deliverables along this journey towards becoming a more equitable healthcare system. And so it is really designed to facilitate system change over time. And one of the levers of change in that transformation model is data collection and stratification. So we are really pushing the field to move forward from, just collecting real data, for example, to moving into other spaces like SOGI data, sexual orientation and gender identity data, data around the societal factors that impact one's overall health and well-being.
So maybe Dr. Schaffner or Dr. Caban Elizondo, what does that look like in your organization, right? Of collecting, what does your data look like today? What are your goals for improving that data? And what are the challenges in doing so?
I'm certainly glad to tackle that with respect to Highmark Health and even more broadly with the Blue Cross Blue Shield Association, of which we're part of. So certainly to start, we absolutely believe in quality and accurate demographic data, including race, ethnicity, and language, and SOGI data, which Joy alluded to in her discussion of what AHA is doing. We have been doing a number of initiatives in conjunction with BCBSA, but also within Highmark Health, specifically to leverage technology and data to improve what we have and to continue to grow the information that we have available with respect to social determinants as one key area. No one area has pushed us, I think, harder as an organization and within more broadly the BCBSA than COVID-19. We know that vulnerable communities were definitely much harder to reach in terms of vaccines, in terms of care. And so we entered into a number of different arrangements to advance not only identifying individuals to support them through the pandemic, but also that would help us continue to build toward quality data. One of those is the Rally for Recovery Commitment, which is a public-private initiative within the federal government that protects employees, encourages vaccinations, and educates staff, local communities on ways to mitigate the virus. And we have to have data in order to be able to do that. Data is the lifeblood of anything we're doing to help and save lives. And again, we know that COVID-19 has pushed us much harder on that. Within Highmark Health specifically, we leverage data very heavily as a part of a number of initiatives that we undertook to accelerate getting COVID-19 vaccines out into our communities. We partnered with a number of organizations in our, what we call our footprint, such as the Pittsburgh Pirates and Dick's Sporting Goods as two key examples, and then leverage data to identify vulnerable populations and do outreach to them that included enabling supports like getting them transportation to sites of vaccines. Again, very critical that we had appropriate and as clean data as possible to be able to do that. You know, one of the biggest challenges to getting to stores of race, ethnicity, SOGI data, et cetera, is collecting it. We can collect that, for example, in Pennsylvania, but we can only collect it after someone has, on our payer side of our organization, has enrolled in one of our plans. We cannot ask for it certainly as a part of their enrollment. And that definitely is an appropriate thing to do because we cannot use that for underwriting purposes as one example, but it also gives us a bit of a lag in terms of knowing who those patients or members are. So one of the areas that we really want to focus on is getting to having industry standards across what can be collected, when, and how it can be collected. And that is not something that as any single organization or even a collection of organizations independently can do. We really need a multi-industry coalition to do that. And I will add that another source, and it came up, I think, as one of the Q&A questions that we've heavily leveraged to, again, try to improve the volume and the precision of what we have available is to work with health information exchanges to be able to get that information, but then also building around that a set of standards and, quite frankly, ethical standards in terms of how that information gets used.
Dr. Fishman, maybe if you would comment on from Family USA's perspective.
Yeah, so I think that the work that Lisa and Joy were just describing is really critical groundwork, but this is an area where we still very much have work to do, both in terms of laying out some standards and really figuring out as a matter of policy when the right time is to ask people about their demographic and SOGI identity and who the right party is to ask that question in a way that we can start integrating stratified data, not just into operational initiatives that providers are taking, but into pay for performance, right? And that's really the next step. And I would note, I think a lot of the best work on how to do that is happening at the state level in Medicaid programs. There's a resource that Families USA put out late last year, which I will put up in the chat, that describes some of the work in particular that Oregon and Minnesota have done in this area. It's not that there's a silver bullet, but it's just making progress between Medicaid plans and providers in how to most accurately capture this data. And if you're going to do P4P on it, people are going to insist that it be accurate. And I think that structure is helpful in kind of getting us the last mile in collecting that data.
Thank you. And Dr. Caban-Alexander, I'd love for you to comment, sort of help us transition to the next question of, with this data collection, right, there are literacy issues, there are privacy issues of individuals understanding why they're being asked this data, for this data, how it's protected, how it can and cannot be used. I'd love from your sort of delivery system side, if you wouldn't mind commenting on that.
Sure, I'd love to, thank you. So this is really boots on the ground comment, right? Because we work face to face with patients who have these who have these barriers in not just accessing data, as I mentioned before, but understanding it. So I'm here for everything Lisa and Elliot have said so far. I totally agree with you. Let me give you an example. We frequently receive calls, let's say complaints, from patients who don't understand why their health information from physicians they've seen at UCLA is shared with a physician in another state. How did this happen? Who said that was okay? Nobody asked me. And we work with them, obviously. So in my institution, the default is on for health information exchange. So patients are not, we don't ask that question. And years ago, when I was at Stanford and we were just in the very throes of trying to understand how we should approach sharing information for patients, we developed a form. Every patient had to consent, and it was a very laborious process. So now, fast forward many years, now we're at a point where, nope, default on, because it makes clinical care sense. We need to understand what's going on with the patient. Plus, we want to collect that data. The problematizing this then is that we've now created an education gap. We've now said, okay, entire patient population, we're going to share your information because it makes clinical sense for us to do so. But we haven't really done a good job of telling you why and how not, if you want to opt out, which they have every right to do. And as you've already mentioned, California has its own special, very strict guidelines around all of that. The other complex layer of that is when you start to integrate race, ethnicity, and class, and the intersections of how these patients are involved and navigate this very complex healthcare system. Because now, explaining to them and helping them understand and encouraging them to interact with the healthcare system within the health information exchange technology, using that as an example, becomes yet another type of discussion. And so the only other thing I wanted to add is that, we are using, we have the ability to capture, all of these areas in our demographics. We implemented the identification of SOGI a couple of years ago, actually right before the pandemic. And we did a lot of outreach in the health system, a lot of education. Remember that the individuals that are collecting this information for patients who want to identify under SOGI are our front desk staff. These are our admissions, registration, our clinical front desk staff. And they're all well-trained, they're phenomenal. But it's not, these are by and large not clinicians. And so it is not a Herculean effort, but it is something that needs constant attention, I think.
I think that leads to a great point, right? If there's this concept that was certainly part of my medical training of, you don't do an assay, an imaging, any kind of test on a patient if you're not going to use that data to drive your clinical decision-making and to the benefit of that patient. So knowing that we are tight on time, I would love, if there've been a couple good examples shared around the pandemic, and I think that is where a lot of this data over the past 18 months has been used to try to get at vaccination efforts, et cetera. But if each of you, either in your organization or sort of a poignant example, has an example of how you are or how you would like to see this data being used, in the active benefit of patients, that would be great if we could do a quick roundtable on that.
Glad to kick that off. We, again, working with the Blue Cross Blue Shield Association, but also independently, are collecting data, are estimating data, are providing data across our footprint in a number of ways to connect our patients and members to resources that can help them on their health and their social needs. One way in which we've been doing that is working with an organization called Aunt Bertha. We launched an online social resource tool where employers, employees, others, other patients and members in our organization can go on and find resources, as well as our clinicians can do that in partnership with patients and members to help them get to what they need. It's important to certainly have that information at the level of patient care, where care is being delivered, be able to provide a set of community resources that a healthcare clinician or provider can put in front of that patient, or work with them, or have members of their staff work with them to access, to help address some of those needs as much as possible. One way in which going forward we're going to be expanding upon that is to build a social needs network. We were recently awarded a very generous grant from a local foundation, the R.K. Mellon Foundation, to do just that, to take data that we have readily available through our partnership with Aunt Bertha, and to expand on that partnership, again, to provide information that can be leveraged to help patients direct themselves or get support with getting directed to social resources. So I think to the point that was being made previously, it is absolutely critical that if we are going to collect the information, that it is used to improve the health and the lives of the individuals about whom it's being collected. So again, just some ways in which we are actively at Highmark Health doing that.
I'll jump in and just share that we, to Lisa's point, we'll know that we are making progress when the very communities for whom we're solving for these health inequities for provide the feedback to us that their experience with our healthcare systems are in fact different. And so we at the AHA know that our resources that we're providing to our members are making an impact. When we look, for example, at the applications we receive each year for our annual coveted Equity of Care Award, which is really, it brings forward for other hospitals to see some leading edge examples where organizations are just really tireless and are being intentional about their data collection efforts, among other actions. But since we're talking specifically about data-driven care, we also track the field's progress through the AHA's annual survey. And we also do, the Institute for Diversity and Health Equity does a biennial survey of the field. And so we can tell the hospital story writ large at the field level as to where we are on achieving more equitable outcomes, and breaking it down around certain criteria like leadership, data collection, community partnerships. There are a whole series of factors that we consider. And the long and short of it is that there's significant work still to be done. But providing the resources to the field to really ensure that folks feel equipped is one of our key priorities. We recently earlier this year, issued a health equity resource series, which again are toolkits, again, action-oriented. One of them being on data collection, validation, stratification, and how do you apply it to that care experience to inform shared decision-making in that clinical encounter, if you will. And so I think our systems are up to task in terms of understanding the importance of collecting the data. I think that case has been made both at the patient level and at the aggregate community level. And then the bigger to do is to take that data, put it in some sort of a dashboard, ensure that it's part of the organization's safety and quality engine, if you will, and then use the information to really guide decision-making.
So I think one of the critical lessons from the pandemic, and this applies both to telehealth and to the use of community-based provision, whether that's community health workers or other kinds of community-based provision, is just the tremendous power of being able to have clinical interactions with people in their homes. That has been a real gap in our healthcare delivery. We have built out, I think, some of that through telehealth in a terrible emergency, and then the vaccination efforts in some parts of the country. Also, there has been some home-based vaccination, and that's been a really powerful intervention where we've been able to do that, particularly in terms of reaching underserved areas and in terms of reaching communities of color. Like, in the neighborhood is better and in home is best. And there's really a lesson from that we should take beyond the pandemic in terms of building up that community-based and home-based delivery capacity. And when we think about problems, for example, like maternal mortality, having more both workforce strategy and covered benefits strategies around having home visiting interventions or early childhood to, like, there are lessons that we can take from what was successful in the pandemic. And I think that's one of the most important ones.
That's a great segue to you, Dr. Caban Elizondo, to maybe from the delivery side.
Yes, thank you. So yeah, telehealth was a saving grace for the health system. And what I can say is that, to your point, we were doing telehealth right before the pandemic, but it was just burgeoning, right? We had our practitioners, our providers, our care teams are like, yeah, we have telehealth visits, but it was nowhere near what we're doing today. And we are investing in continuing this. The other thing I just wanted to mention, I'm really proud of the care team at UCLA that developed this. A few years ago, they had a grant to go out into the community and to take care of the indigent community in Los Angeles. And it's no secret, there are many that live on the streets in and around Los Angeles, throughout the San Fernando Valley, on the west side, the east side. And that was their goal. And it was medical students and residents and attendings and nurses. And it was just phenomenal. And it is now a full-fledged program. And what we're doing now is figuring out how to ensure that they have the technologies live so that they can capture this information. And the last thing I want to just mention real quick is, I love all these discussions. I'm here for all of it. I think it is rich and I think it's needed. And the only thing that I just want to make sure we're all, and I know we all are, just remind ourselves that we have to make sure that patients are along with us on this ride. Because we can implement any technology, we can, policies galore, but when it comes to really ensuring that the patients understand and they see the value, it's almost like spinning our wheels, right? And so that sort of, I have soapboxes. That's one of mine, is really making sure that the patients understand the value of their health information and why it's being used and how it can help them be the pilot of their healthcare.
Thank you. And I think that's just a great place to sort of bring this conversation back to, right? That this entire conversation is framed around, how do we use data and technology, collect the right data, but always with that end game of we're doing this to try to serve all patients, as you pointed out, and identifying their unique characteristics, their needs, such that we can construct the interventions. And to Dr. Fishman's point, that the data to align some of the payment models behind this, right? As we move to a value-based system, nobody can take risk on something that they can't quantify the risk and understand really what all this data means. So it's a big challenge, and I really appreciate this very talented panel's input on this topic today.
Great. Well, thank you again, both to our moderator and our panelists here. We are so pleased to have such a robust discussion. And our next speaker here is going to be Catherine Okar. She is Special Assistant to the President for Community Public Health and Disparity.
Hi, can you hear me okay? I thought it just cut out for a second, but am I good?
Hi, Catherine, we hear you. I might have been talking to myself on mute. Apologies for that.
No, that's okay. I don't know if you heard, you might have heard me. I was like, oh, did I lose them? So I'm so glad that you're still here.
Yes, we're here. We're here. All right. So I will, I don't know if you heard me when I was thanking our first panel, but thank you to our first panel and moderators for that excellent discussion and really thought-provoking discussion. So our next speaker here is Catherine Okar. She is Special Assistant to the President for Public Health and Disparities in the Executive Office of the President. Just to quickly run through her bio, she most recently served on the Biden-Harris transition. She was also a senior advisor at Waxman Strategies, consulting on public health, nutrition, and healthcare issues. During the Obama-Biden administration, she served at the White House as the Associate Director of the Let's Move initiative in the First Lady's office, and as a senior advisor in the Office of the National AIDS Policy. Catherine was also the Director of Public Health Policy in the Office of Health Reform at HHS and began her work in DC as a Winston Health Policy Fellow. She has conducted community-based research with low-income cancer survivors and safety net clinics, and she graduated from Notre Dame and the University of Michigan School of Public Health. And is hailing from Cleveland, Ohio, or outside Cleveland, Ohio. So thank you for being here today. And we are just truly thankful to be able to hear your thoughts on how this administration is approaching these important but difficult issues.
Great. Well, I'm so delighted to be here. Thank you so much for having me, Kristen, and the Surround team and everyone else here, along with my esteemed colleagues who I just heard before and earlier in the session. It's great to be with you all today. So my charge is to talk about the administration's efforts to enhance our public health IT and data infrastructure, and when we're thinking about tackling not only current public health threats, but future public health threats, and certainly doing so in a truly equitable way. And so I wanted to start kind of big in terms of when we're thinking about health IT infrastructure, at least from the federal perspective, we're really conceptualizing it with three core pillars. So one, the healthcare delivery system, meaning EHRs, health information exchange networks, the payment system, which I think was talked a little bit about just in the previous panel, and then the public health system, which I will talk mostly about today. So that is everything from the CDC systems to state and local health department systems, vital records, syndromic surveillance, lab and case reporting. So historically, really the preponderance of our health IT investments have been in our healthcare delivery system. Things like the HITECH Act of 2009, which created much of our current health IT infrastructure as we know it. And then certainly the Cures Act signed by President Obama, which really required a lot of use building on that infrastructure and bolstering things like interoperability or requiring instead of permitting information sharing with patients. Now, HITECH undoubtedly served as a catalyst for broad adoption of health IT across the healthcare system. But we know that progress in our public health system and our public health system, that third pillar that I referenced, has been comparatively slow. And so it was really, for better or for worse, the COVID-19 pandemic that exposed and really put front and center a lot of the structural and performance gaps and fragmentation of our public health IT system. So for example, we know and have come to realize even more that the fragmented and limited availability of data by race and ethnicity and geography and disability delays our recognition of risk and our capabilities to have a targeted response. We also know and have come to realize firsthand that our public health systems are often siloed from clinical care systems, so from our EHRs, from our claims data. There's a lot of variation in data completeness and quality across entities that are reporting. There's an inability to aggregate information across data silos. And there's often inflexible, non-standardized technology, compounded by the fact that, as the previous panel was just referencing, insufficient data to really assess health inequities. And so the pandemic has required us to have a really historic response effort, frankly, including an ongoing improvement of our national data to inform decision-making. So a few things that we've done to address this. On day one of the administration, President Biden issued an executive order to ensure a data-driven response to COVID-19 and future high-consequence public health threats, which really told us as federal agencies, as the federal government, that we needed to expand and directed us to expand our data infrastructure to increase collection and reporting of health data, especially for high-risk populations, all while reaffirming data privacy. So how have we done this? So some of our efforts on this front include things like creating an interagency working group that provides analyses to leadership, to response leadership on a daily basis. We have, and some of this stuff is so cool. I have to say, as a public health person, it's like so cool to see the products and the outcomes and the information that is informing our decisions on a daily basis. There's also a new the new HHS Protect platform, which the health IT experts on this call can probably speak way more articulately about than I can, but it includes data on healthcare system status via daily reporting from over 6,000 hospitals. And then certainly, as I'm sure many of us are familiar with, as the CDC's COVID-19 data tracker. And so that is enhanced weekly and has reports on pediatric data, health equity data, and vaccine effectiveness. And then we're consistently, or I should say our COVID team is consistently engaging with jurisdictions to improve the completeness and quality of equity-related data. As we keep talking about it, it has so often been so incomplete. And so, for example, the completeness of race and ethnicity data reported to CDC through jurisdictional systems is about 65%. But it's up to about 78% for the current week, which is really extraordinary. And so I started off pretty zeroed in. I'm going to start kind of backing up a little bit by little bit as I go along. So in addition, the CDC has also established a new Center for Forecasting and Outbreak Analytics, which just launched in August of this year, with a goal to model and forecast public health concerns and share that information in real time to trigger governments, private sector, the public to respond, both domestically and abroad. It is really meant to inform public health decision-making, bringing together public health data with expert, brilliant disease modelers and data scientists, and of course, public health emergency responders. So why is this a big deal? It really meets an important and unmet need of having a focal point for federal forecasting and analytics. It undoubtedly is improving and will continue to improve the ongoing COVID-19 response, but also help us prepare for the next pandemic. So in order to do this work, the center is really looking at new and existing data streams to paint a big picture of what the emerging public health threats are. And so this I think the center is like the coolest thing ever. And it's not the only piece of the puzzle. This is actually part of a bigger multi-year data modernization initiative by CDC. And that goal of this, what's called the DMI, the Data Modernization Initiative, is to really modernize the data and surveillance infrastructure across the federal and state public health landscape, which we know has needed that love and attention. The DMI was started in 2020. It got some additional support from the American Rescue Plan. And it's really not only bolstering that infrastructure, but it's truly advancing health equity because it's making public health data more complete. It's making it higher quality. It's incorporating data points on race and ethnicity, and frankly, making data more representative of all people. That means it's tapping into new quote unquote non-traditional sources of data to paint a fuller and more comprehensive picture of health disparities in this country. And essentially, it will move us from what has historically been a siloed and brittle public health data system to a more connected, resilient, adaptable, and sustainable, quote unquote, response-ready system. It's also, of course, meant to bolster some of those early warning signs, but then also, you know, we can have the greatest systems in the world, but if we don't have the workforce to operate them and develop them, it's all for naught. And so the DMI has also supported, and I'll talk a little bit about the workforce in a moment, but the Data Modernization Initiative has also supported and enhanced pieces of CDC's syndromic surveillance. And so I think it sends about 6 million messages a day, which are received, like I think it's 75% of data are received within 24 hours, which is like, this is emergency room data to the CDC system, which is really incredible if you think about it. 71% of the nation's ED report data is sent to the CDC syndromic program. It's really quite incredible if you think about how much data is being fed and how much information is being processed. And so in addition, you know, I was talking about the CDC initiatives. These are even part of a bigger, larger effort to enhance the public health IT system. My colleagues in the Office of the National Coordinator for Health IT are doing some amazing things, all undergirded by a focus on equity. So for example, they're developing a program called Health Equity by Design, which is all about incorporating health equity considerations into health IT design and development and implementation and use. They've added social determinants of health and SOGI data elements to their minimum data set requirements for EHR systems. And to my point earlier about having workforce to really operate and develop these technologies and this infrastructure, ONC has just, or the Office of the National Coordinator for Health IT has just launched an $80 million public health IT workforce development program targeted to minority serving institutions. And the goal of this is to train over 4,000 individuals over a 4-year period through a really interdisciplinary approach in public health informatics and technology. And this is really part of our commitment as the administration, and the president's commitment to hire public health workers from the hardest hit and highest risk communities. And frankly, to ensure that there's a steady stream of talent, of diverse talent across the U.S. public health system to equip the country for the current pandemic as well as future public health emergencies. My colleagues here at the White House and across the government are also part of what's called the Equitable Data Working Group, which again was also established on day one of the administration to identify, frankly, the inadequacies in our existing federal data collection infrastructure and to lay out a strategy for improving it. They have a report coming out, I believe, this fall that will communicate some of the barriers and the gaps to equitable data collection through a number of case studies that they're pulling together, and certainly they've been doing a ton of consultation with agencies and external stakeholders. And really the end goal is to have regular, systematic measure of equity and inequities throughout the federal government. And so we know, though, that if we improve our health data collection, if we improve our IT infrastructure, that it doesn't operate in a silo. And so that's why we're really thinking about healthcare, the healthcare system broadly. And that's why we're focusing on, as I'm sure you will suspect I will say, building it back better. And that really includes making things more affordable. And so as we're thinking about how to improve the IT infrastructure, we're also thinking about how to improve the healthcare infrastructure. And that includes lower health costs. That includes lowering premiums for people who buy coverage through the ACA. That includes closing the Medicaid coverage gaps for low-income individuals. And that includes lowering prescription drug costs and certainly expanding Medicare to help seniors access services like dental and vision and hearing, so that when we detect disease via these enhanced IT infrastructure capabilities, people have the ability to get the care they need when they need it. And I'll just close by saying, we're really in such a pivotal moment in our public health IT and data infrastructure, and frankly in our healthcare system at large, as we're thinking about how to, as my previous panelists talked about, really leveraging the increased use of telehealth. We're thinking about that a lot in the administration, and how to leverage a lot of the lessons learned and that are still being learned from the pandemic to improve the healthcare system, and how to tackle issues and leverage the enhanced public health infrastructure to tackle issues like, as I think Elliot said, maternal mortality and chronic disease, and the list goes on. And so certainly we have lots more work to do to ensure that we tackle the current threat we're facing with COVID and others, and future threats to make the system better for every single one of us. But we've made significant progress, and we're just getting started. So with that, Kristen, I think I will turn it back to you. Hopefully that was helpful.
Great.
Happy to answer questions offline. I know you've got to move on to your next folks, but really appreciate the time.
Yes, thank you so much for being here today and for sharing with us sort of your priority topics and how you're thinking about this, and certainly definitely some things to watch moving forward. So thank you again for being here.
Sure, thanks for having me.
Great. So with that, I think we will start the transition to our last panel of the day, our second panel, which is focused on modernizing and advancing public health. The goal of this panel is to explore current efforts to modernize and intentionally rebuild our public health systems in the aftermath of COVID-19. So we are fortunate, I think people are being brought up on the screen here right now, but fortunate to have Molly Murray from the Pew Charitable Trust as our moderator for this panel. We will be joined by Amanda Kavanaugh, who's a senior program manager for the Center for Health Information Sharing and Innovation at the Illinois Public Health Institute. Ashok Chenaru, Chief Data and Analytics Officer at Anthem. Dr. Annie Fine, who is the Chief Science and Surveillance Officer and a Senior Advisor to the Data Modernization Initiative at the Council of State and Territorial Epidemiologists. And Morgan Hone, Executive Vice President of Contexture and Chief Executive Officer of the Consortium for State and Regional Interoperability. So HIE networks in Arizona and California. I will turn it over to you, Molly, to go ahead and kick things off.
Great, thanks. Good morning, everyone. Thank you so much for inviting me to moderate this panel full of such excellent speakers and on such an important and relevant topic. Like mentioned, my name is Molly Murray. I'm a senior manager for the Pew Charitable Trust's Health Information Technology Project. We do research and advocacy on a variety of health topics, mainly related to interoperability. And recently, our work has begun to look into how some policy changes could enhance the data sharing with public health agencies. And at the start of the pandemic, we thought that some of the issues that we've been reading and hearing about had related to some of the health data exchange issues that we've been tackling for the last few years, and began to investigate to understand how some of those solutions might also work in the public health field. So the panel is full of experts who have many more insightful things to say than I do, so I'm thrilled to be able to introduce them all. Each speaker will have a few minutes just to give an overview about the topic and their work in public health and public health infrastructure, and then we will move on to moderated questions. And as time allows, we hope we'll be able to fit in some questions from the audience as well. So please share those in the question area or chat on Zoom, and we look forward to the dialogue. So first, I'd like to introduce Amanda Kavanaugh, who's the Senior Program Manager for the Center for Health Information Sharing and Innovation at the Illinois Public Health Institute and Data Across Sectors for Health. Amanda?
Thanks so much, Molly. I really appreciate it. Also want to just appreciate the rest of the panel speakers from today. The conversation and dialogue has really been wonderful to see these bright spots happening around the space. So thank you for the opportunity to participate. I work for the Data Across Sectors for Health organization, also known as DASH. And DASH has been working for quite some time within the multi-sector data sharing space, and specifically around building local capacity So those efforts focus on really 3 key strategies. We look at the way that we help communities build capacity. We look at the movement across the space and the types of partnerships and collaborations that are going to center on equity and the community voice and persons with lived and learned experience, but also working on the evidence base. So the types of grant and philanthropic efforts that we produce are geared around the community's role in lifting up these areas where we see systemic injustice, historical racism, some of the challenges around access and underserved communities. And so right now we're in the process of launching a second round of our Learning and Action in Policy and Partnerships grant. So about a year ago at the start of the pandemic, DASH took a hard look at sort of where priorities may have shifted and focused our grant on bringing the community and the state together on these data sharing collaboratives. So we're running our first cohort. We're 6 months in and are seeing some really great findings, including legislation coming out of this community-focused multi-sector data sharing partnership, governance structure and alignment between community and states. And speaking about the public health integration aspect, DASH is mired within 2 public health institutes, Michigan and Illinois. And the second round of our funding for LAP is focused on the utilization of COVID relief bills that have been made available. So billions in dollars. We're focusing the grant opportunity on those that want to bring the multi-sector data sharing piece into the larger American Rescue Plan Act, the COVID relief, the CARES Act. So how can we capitalize on current funding to build sustainable efforts around community data sharing? And how can we ensure that that has the capacity to continue even after grants are closed? So that's an area where we're focused right now. And that's really how we see our role in the space. We operate both as DASH and we have a partnership with the All In Online Community, which is based up of all of our community partners, state partners. There are legacy grantees. It's an area where you can not only network, but it's also an opportunity to learn more about the type of work that we've been doing in communities. And again, all of our work is supported through our partnership with the Robert Wood Johnson Foundation. So just thrilled to be on the panel. Hopefully that was short and sweet, or maybe at least entertaining, and I'll pull back. Thank you.
Thanks so much, Amanda. Looking forward to hearing more. Next, Dr. Amy Fine. She comes to us as the Chief Science and Surveillance Officer at the Council of State and Territorial Epidemiologists and Senior Advisor to the Data Modernization Initiative.
Thank you so much, Molly, and such a pleasure to be here as part of this conversation. So I currently work for the Council of State and Territorial Epidemiologists, which is a member organization of all the states and territories, and we also have a lot of local epidemiologists who work with us. We have about over 2,200 members of applied public health epidemiologists, people working in the trenches in the state, territorial, tribal, and local health departments. This is a new position, and my position is to work on data modernization, but I'm drawing on a lot of experience that I had working for 25 years at the New York City Department of Health as kind of a frontline epidemiologist in public health. So I'm trying to bring that experience to this work. So I will reiterate some of the things that have been said already by Catherine Oker as well as by Amanda, that public health has been chronically underfunded, especially in comparison with some of the investments that have been made in healthcare technology over the past 10 to 15 years. And authority for public health data reporting does reside at the state and local level, and it is really critical that data be available and that we have a skilled and talented workforce and capable, sufficient workforce to analyze those data and respond at the state and local level. And that way we can really support communities as they face these kinds of public health threats. This is really critical. So while we need data at the federal level, we also really need it at the community level. So public health across the country, very stressed right now, very under-resourced, and capacities are really variable. So data modernization poses a really big challenge because we have some places where public health is fairly robust and there are systems that are working and they're good and they work well, but we also have areas where we really need to do a lot of building, and we definitely need to work on interoperability and scalability. COVID proved this in a very tragic way in a lot of ways. Our systems at the state and local levels were not robust enough to handle the volume and complexity of the COVID response. And our workforce is exhausted and stressed. And so now as we try to build back, that is the workforce we're relying on. And I think we need to be realistic about what we can achieve in a short time frame. The funding that has been received is wonderful and much, much appreciated, but we do really need sustained funding in order to really build a better public health infrastructure and workforce. We have reporting streams, which in the past have been, many places still are, paper, fax, phone calls. We burden healthcare with all of these kinds of data streams, and we really need to work hard on electronic case reporting and other ways of getting data out of the healthcare electronic records. We have issues with now healthcare being able to send data and health departments not being able to ingest the data. So we need to really focus on that. We're really excited that this was part of the promoting interoperability rule that just got issued for the inpatient sector, mandating certain public health electronic reporting streams. And we hope that it will be in the ambulatory rule as well. And we, this was emphasized the really critical need for getting better data, higher quality data on especially race and ethnicity and other issues related to health equity. And there are ways to do this. We need to collect it better at the source. We need to represent it in standard ways, and we need to have it be included in electronic test orders so that it could be included in electronic laboratory reports. We need to do a lot better at data sharing across jurisdictions and with the federal level. So all of this is going to require really strong collaboration. We've started on working very closely with our partners, CDC, other health associations at the national level, as well as all of our member health departments. And this is going to require deep engagement and collaboration, testing, iteration, and I'm really excited to be a part of it and look forward to the conversation.
Thanks so much, Annie. And next we have Ashok Shanuru, the Chief Data and Analytics Officer for Anthem. We have so many people with data in their titles, so apologies, I keep stumbling.
Yeah, thank you, Molly. Really appreciate having us here. Yeah, Ashok Chenuru, I serve Anthem as the Chief Data and Analytics Officer, and at Anthem, we serve over 110 million consumers, including 44 million health plan members. So that translates to a lot of data. So one of the foundational investments we started several years ago, and we accelerated it recently, is combining all the data we have, whether it is the traditional administrative data we have from our platforms, and integrating that with external data, both structured and unstructured, from the providers, the medical records data, the ADTs, and even getting data from wherever we have opportunity, like the state HIEs, etc. That includes race, ethnicity, language that a lot of the panel members talked, and health-related social needs, behavioral health data, and some of the emerging data set, genomic, and home health. So we aggregate all of this, into what we call a lifetime, patient or a member record, and that becomes the foundation for a lot of the analytics we do. And in a lot of cases, we take those insights and even send it back to the, the provider so they can integrate it into their workflow. Or we even provide, FHIR-enabled API services where we can share that with all the, the third parties, as part of the ecosystem. We have been laser focused on, collecting, the immunization, registry data where it is available, or even, focused on getting data on, for broadband access, we are closely partnering with the association as well, on, seeing where the opportunities are, for broadband that would improve access to care, from a telehealth standpoint. So interoperability has been a enterprise priority, for Anthem, and it serves as a foundation for, how we have, really operated or been able to, stand up, a lot of different tools, like for the last 18 months. So for example, at the onset of the pandemic, we offered a AI-based symptom checker, for all our members as the first line of defense, and from there a seamless transition to a virtual, a provider visit, and then to a in-person visit if needed, and data interoperability, served as a foundation for, from digital first to virtual to in-person care. And we have also actively participated in a lot of the ONC related, committees for data exchange, and because of our footprint across the country, we have been able to influence, a lot of the different parties on data sharing, and we have been, really forthcoming related to what data is needed, all the insights that we have been, including predictive insights from both structured and unstructured, that we have been able to, garner, if you will, that we want to make available. A big focus for us is definitely on, health equity. We have, collected a lot of data, both at the member level from a Z codes or from a zip code level that we have integrated that along with behavioral health, and pharmacy and medical, et cetera, and have, shared it with our care managers. So when we do outreach, we are focused on the whole person health, versus just looking at them more from a clinical standpoint, and also leverage some of this health equity data to support the most vulnerable population, across, our different states. So in a nutshell, we, at Anthem, we call data is the heartbeat for, everything we do, and interoperability is the foundation for how do we leverage the power of data that we have and we collect and the insights that get generated so we can really support the whole ecosystem. Thank you.
Thanks so much. I love that, the analogy about data being the heartbeat. I may have to borrow that. And next, Morgan Honea, the Chief Executive Officer of the Colorado Regional Health Information Organization, as well as the Chief Executive Officer for the Consortium for State and Regional Interoperability.
Thanks, Molly. So good morning, everyone. Just landed in Phoenix, so had a little bit of challenges getting online this morning, the joys of working both remotely and not remotely, I suppose. So my name is Morgan Honey. I'm the previous CEO of CORIO, which is the Colorado Regional Health Information Organization. Recently moved into the role of Executive Vice President for Contexture, which is the new organization bringing the HIEs in Colorado and Arizona together, covering over 18 million lives. And then also serving as the CEO of the Consortium for State and Regional Interoperability, which is 6 of the largest HIEs in the country, representing over 80 million lives. I suppose I would go back to all of the things that Dr. Fine said and demonstrate or illustrate the resources that HIEs can provide and support in terms of public health response. I started my career 20 years ago in public health, and got a firsthand view of how poorly resourced our public health HIT infrastructure has been historically. I remember at the beginning of my career using Excel spreadsheets and Word documents from ERs to understand after hours, coming to the realization that a lot of kids with earaches and parents that couldn't take it anymore show up in the ER when urgent cares or primary care isn't open at night and on the weekends. So I've been doing this for a long time and certainly understand the challenges. I think, what HIEs across the country would really like to demonstrate and help public health understand is that we are willing and capable partners in terms of providing responses to pandemics and public health emergencies. In Colorado, we've had a long-standing partnership with our public health department, starting with building those interfaces to ELR systems, to immunization information systems, and so really serving as the conduit between the investment that's been made in the private sector from the Meaningful Use Program and others, the adoption of electronic medical record systems, and then doing our best to make sure that information is bidirectional in nature. So not only does it provide support to the public health departments in terms of their necessary reporting requirements, but then also makes sure that we have the data in the hands of the providers who are actually taking care of the population as they see them. So not only do we need to make sure that the data is flowing into IAS systems and ELR systems, but also that the data can come back out of those systems and into providers' hands when the patients arrive in their facilities. So that has been our focus, and I'll just share one use case that we tackled early on at the beginning of the pandemic is, again, to Dr. Fine's point, we realized that a lot of the time data collection as it's submitted into public health departments is not great. It's not complete. Many times it's not standard. And actually all three of those things are kind of the core of what HIEs do. We use very heavy technology, very expensive technology to complete that data, to round out the demographics information. And so early on in the pandemic, we've partnered with our public health department to turn those interfaces from the ELR system into bidirectional interfaces so that providers could have access to the data, but then leveraged our infrastructure to enrich that data so that the demographics coming into the IAS systems and the ELR systems were as complete as we could possibly get them using our master patient indices and some of our terminology services solutions. So recognize the partnership that HIEs can have in response to these types of emergencies, but also to advocate for the data and the interoperability that we're talking about is bidirectional. It's just as important for providers to have access to it, patients to have access to it, but also for public health to be able to aggregate it and report it to the different required agencies that they have on their list. So Molly, thank you for having us today. And
Thanks so much. I love the focus on bidirectionality. I imagine that will come up a few times as we get through some of the questions. So over the past year, we have all learned a lot about how data can be used for a range of different healthcare purposes. For example, targeting testing and vaccine distribution to at-risk individuals, or providing care virtually and in other settings outside of a healthcare facility. We have a series of questions related to this topic, so feel free to jump in when you can, or else I can always call on folks to keep the conversation rolling. So first off, what role does public health infrastructure play in pandemic and public health response? Maybe I can call on Dr. Fine to start us off on that topic.
I mean, that's like kind of a no-brainer. I mean, public health infrastructure is critical. I mean, that's, it was so evidenced by what has happened over the last growing number of months. I think for a long time, we've been advocating to improve the public health infrastructure. And I just think that the funding hasn't been there. And so, there was a lot of funding that was part of the High Tech Act but there just wasn't as much attention to the public health side of things. Public health departments receive data, investigate cases, work directly with communities, and then do provide data to the federal level. But I think without that capacity, both technically as well as workforce, this just swamped us, this event. And I think it's a bad thing and it's a good thing because now we know, but we have to seize this moment.
Thank you. And I might just build on that with the next question because you set us up perfectly for it, which is where are we now with data and tech differently from than where we were before the pandemic? So how has the pandemic helped some of that infrastructure or tech improve a bit over time? And I'm sure Morgan has some examples to share with us as well on that topic.
Sure, Molly. I mean, I would again highlight what Dr. Fine said, right? You had billions of dollars flow into the high-tech program. And quite frankly, if these problems had been solved, then organizations like mine wouldn't need to exist. And so I think that, the sad but good reality, I suppose, is that the pandemic did shine a light on the fact that we have not invested in our public health data infrastructure. But I think what it has demonstrated is that in response when systems get swamped, when we all go home and start working virtually, that partnerships really can come out and shine in response to those things where underinvestment where investment hasn't been made historically. And so I think in Colorado and Arizona in particular, you know, everybody had to go back and get creative and say, you know, we're here, we can't do anything about it, we've got to figure this out. Everybody's getting buried. And so what can we do? And I think that it really forced us to take a different look at how we try to provide solutions to these challenges, when we recognize that, you know, I may have started my career in public health, but I don't work in public health anymore. But, you know, I want desperately to get out of this pandemic. And so I'm going to throw every resource that I possibly have in my organization to try and help the public health department solve it. I think if you dig a layer deeper, you know, I'll use myself as an example. I got my COVID vaccine in a barn in Clear Creek County as soon as I possibly could. I filled out a paper form and handed it to the person in the parking lot and got shot in the arm and then drove back down the mountain. That data collection process is pretty abysmal. I can guarantee you that whatever my data looks like in the IAS or the, you know, the immunization information system, it's reflective of the scribbles of my third grade writing on that parking lot in the barn in Clear Creek County. So how can we just all throw our resources into the pot to try and help out where we possibly can? And I think what it shined a light on is, you know, right now, because of the partnership that we have with CDPHE, which is our Colorado Public Health Department, we know that, you know, we're passing the 80% mark for Asians in Colorado being vaccinated, whereas, you know, we're hovering around 35% for African Americans. Finding those types of disparities and really not only supporting the public health department know who's been immunized, but what do they look like? Where do they come from? What are some of those social factors that are maybe impeding them from getting the vaccine? I think that's where we can continue to provide a lot of great support just beyond the initial response. But it's going to continue to require partnerships. It's going to continue for us to, you know, it's going to require for us to all continue to leverage the different investments that have been made, whether it's in the private sector or the public sector, or, you know, nonprofit partnerships like ours. And I think, you know, right, wrong, or indifferent, it forced us to take a different look at how we're doing business and really get creative and realize that, look, let's all throw our let's all throw our cards in this hat and try to get out of this pandemic as quickly as we possibly can. And then I guess my hope would be that going forward, you know, we learn the lessons of the last 18 months and say we can't underinvest in public health infrastructure. We can't ignore the power of partnerships that are out there in our community. And at the end of the day, this is everyone's responsibility, and everybody has a part to play in trying to get out of this pandemic.
Absolutely. Oh, sorry, jump right on in.
I just wanted to add, I totally appreciate Morgan's comments, and I want to talk to him a lot after this session. But, you know, there are things that did work. Like, for example, electronic laboratory reporting. The reason we know how many cases there are or have been of COVID, even though we may not know all of them, is because we made investments in electronic laboratory reporting, and we should not ignore those facts, that some things did work. It wasn't a complete and total failure. However, the reason we didn't know about race and ethnicity is because laboratories don't have that information, and they didn't supply it to public health. So we can fix that. We can if we collect race and ethnicity one time from a person, and they're able to say how they really do identify, and we have ways to capture that in a standard way, that's should be easy to capture in a healthcare setting, and then pass that information along wherever it goes, to the vaccination, immunization registry, to lab, wherever it needs to go in order to be there when we analyze the data, so that we can focus in on the communities and populations that are most severely impacted. And there are, I think, the most important technological advancement that we've made in this pandemic is that we are now talking about it with each other, and that we know we need to make these connections, and we know we need to make things interoperable. Though we haven't done it yet, some things have gotten better. But really, I think the conversation is the best technology that we've built so far. And I think we just need to continue it till we get where we need to go.
Yeah, no, absolutely, Dr. Fine. I would say, like one of the, the other opportunity, at least where we have done well, and I see even a bigger opportunity is, like you mentioned, lab data, even being able to impute, race and ethnicity, because it is going to take some time to establish the standards. Like you said, we have started talking, but being able to impute from unstructured data, from progress notes, from a lot of the public data sets, it may not be, 100% accurate, but at least we have something that we could act on, right? I would say that's a great opportunity. The other area where I feel that we have made really good progress, at least, with an Anthem where we have really great examples, is the admin discharge data. Because when we removed prior auth, there was no way for us to know the hospital census, which of our members got admitted into the hospital or got discharged. So we were able to, take the admin discharge data and send it to the primary care physician that, hey, one of your members has been admitted or discharged, or, here are the discharge instructions, and we started to put focus on it because for certain segment of our population, we saw 45%, readmission rate, within the first 5 days, right? So the hospital systems were already overburdened. So how could we help, the primary care, or how could we help our care managers to reach out to the members based on their complete profile? Are they living alone? Do they have help, right? Do they have other, behavioral health conditions, et cetera? So we could really have a immediate impact. So those are, absolutely some opportunities where I think we can scale.
And so I think one aspect of this is sort of like we talk about data a lot. We talk about data standards. I heard Ramsey and Sean Robbins and Sean Martin in the first session talking about the need for standardization, the need for everyone to have a seat at the table. So while we talk a lot about the data pathways, I don't necessarily Dash sees our role as making sure that like the community that's surrounding those persons in community is really where the focus is. Because while the data isn't where it needs to be, services and supports were provided throughout the pandemic, and they were grassroots. There were community organizations that were doing this work. So the question is, how do we make the privacy, the consent, the discussion about whose data is it and where it goes, and how do we not focus on, there's a great quote from Henry Ford at one point who said, if I'd asked people what they wanted, they would have said faster horses. And so the question is, do we want faster horses, or do we want a system, a continuum that when you move across the space, whether you're working within your community and the challenges the pandemic brought up about homelessness and eviction or food insecurity, or whether you're into the health space, like how do we look at that continuum and about the whole person that we're serving, regardless of the on or off ramp for their data points? We did a research publication last year that was focused on 26 different thought leader interviews. These were state officials, they were state agencies, they were community partners, they were persons in community, and asked them sort of like, what does COVID mean to your priorities? And while the challenges in some cases were the same around population health and how to get out there and have the resources, how to have the capacity, how to not have to rely only on grants and philanthropic efforts, the larger conversation is also, how do you build a vision of this infrastructure and architecture that honors the importance of all those data pieces, but that ensures that when we look at interoperability, we're also supporting the community's role to continue to be the focus for providing those services and supports. How do we do that in a way that manages to all of those complexities? And that report, you had different cities and counties sort of talking about it, talking about the impact of racial injustice and what does trust mean, regardless of where your data is going. What happens when you stand in line for a vaccine? So there's a lot of insights in that article that sort of were from community's perspective about what they saw the challenges were. And I think we need to make sure that we're incorporating that as well in these efforts.
Excellent, excellent point. And you led us well into the next question I'd love to hear from you all on. And Amanda, maybe you can share a little bit more on this topic, which is how do you see that we can use data in new, innovative, more efficient ways going forward that can support that more coordinated community and patient-centric care?
Yeah, so I think one of the questions is who's around the table when we're asking that. You know, what is the need? What is the infrastructure need? How can we support that? And I think what we've discovered is that, you know, by having conversations with communities and hearing from their perspective what the priorities are, but offering opportunities to align the community voice with their data sharing objectives. You know, how do they see their partnerships? Do they have, you know, do the community organizations have the resources that they need to be successful, as opposed to investing in another partner to provide that service? And so we've really worked hard, even in this current round of funding, to say, all right, where is the future of this discussion? And so when there is funding windfalls, like the COVID relief coming out of the Biden administration and the American Rescue Act and the CARES Act, it's sort of like, how can we, like in Dash sees our role, how can we support the multi-sector data sharing part of it? So governance, how do we look at data sharing agreements? How do we help community organizations with readiness and organizational capacity? How do we learn from other communities that have done similar work? How does what's happening in the housing and homelessness space impact what's happening in behavioral health? And then what are the roles for those players, right? So I think we see our responsibility as Dash to provide opportunities for communities to lead this integration effort and for communities to be at that table when we're talking about what types of data are needed, how could it be obtained, and then more importantly, where does that data go? There's been a lot of I don't want to say a lot of, but I think that there's some resistance to every time there's a problem, the answer is give me more of your data and then I'll be able to serve you better. But in these underserved or unserved communities, the legacy has been give your data and then services are not where they're needed. So like, how do we bridge that gap is the other part of where we see data coming into the overall equation and capitalizing on the time and place of COVID funding to build these infrastructures that will, you know, carry past the end of these efforts. So.
Yeah, and I'm gonna jump on the Amanda Kavanaugh wagon here. I think that if I had my way, you know, I think decisions and particularly funding decisions are typically driven by data. And you know, when we were prepping for this call, I think the pandemic absolutely shone a light on the underinvestment in public health HIT. My concern, and I think a huge opportunity as well going forward, is there's a huge focus on social determinants of health in the healthcare space right now. And I you know, if I had if I was reading the tea leaves, I'm going to say that the next light that's going to get shined is the underinvestment in those community-based organizations, the folks that Amanda's talking about in underserved communities, that our healthcare system is going to say, well, you know, I realized that you were having food insecurity or that you were homeless. I made the referral. But there's no one at the other end of that referral with the resources to be able to solve the problem. And I think that there's so many parallels between that and what we've seen in the last 18 months with public health, where, you know, we've got this huge burden and this huge responsibility of historically underfunded systems trying to accept or support, you know, huge swaths of the population, communities with incredibly diverse needs. And, you know, we're gonna sit here and go, okay, well, I made the referral for homelessness, but there's no beds at the homeless shelter, or I made the referral for the food bank, but there's no food at the bank. And so I think that, you know, the opportunity in that problem statement is that I hope we don't have to learn all these lessons the hard way over and over again. But if we do have the data and we can show people, you know, particularly decision makers and those with the purse strings, that look, we've been raising our hands and saying that we needed more resources for years, and now we're shining the light on it and finally have the data to prove it. I think that that's where there's a huge opportunity for all of this conversation to go.
Yeah, thanks, Morgan. I would say, with the data we have, we fully know, and I think the panel members mentioned this earlier too, we are not going to get everything we need, but with the data we have, what are the right incentives for adopting, technologies of even providing, bridges to less sophisticated, systems for adopting some standards. I think that's the opportunity. And then looking at the whole person health, which includes clinical, behavioral, like social, all aspects, so that way we are targeting, the right members in the right locations, and where we can create the biggest impact, because we do have some of the data right now. It may not be complete, it may not be high quality, but with what we have, how do we, maximize the impact?
Yeah, this is such a great conversation. I wish I could go on for a long time. It's really, really stimulating. But I think we really do need to connect our data at the person and community level. And then really importantly, going back to what Amanda said, is we need to involve and engage with communities and community organizations about what are the most important questions that we ask of the data, because it's just data. It's just data. It's just like a bunch of data, and it may be meaningful, it may not be, but it's what questions are you trying to answer, and what are the best ways to answer those questions? And that needs to be informed by, as you said, the communities who we're trying to serve. And so I think that is a big challenge of how to do that, but I do think there are both technical and societal, organizational ways to move forward on this. But that's a really, really critical point. That's why I would love to continue this conversation to try to begin to understand that better.
Agreed. I think we could go for another hour, but unfortunately, we only have a few moments left. So I'll leave with this one question that I think you've already begun to touch on. But what recommendations, if you could make one right now, would you share with Congress and/or the administration?
I would support the importance of the role of community and the role of persons with lived experience in community to not just be a single stakeholder at a single committee meeting, but to be front and center and at the table when these discussions are happening. I think all of these efforts around data capture and system design should focus their efforts inclusive of community engagement, because just like, in the Medicaid and the ACA expansion and in other areas, we see that enrollment, education, information, awareness, and relatability of exactly what's happening with these types of data and what we're trying to accomplish in the long run together is critical, because it seems that we can do better about not bringing that voice to the table after the fact, because ultimately we want communities to be able to work together to thrive. And so I think that's the one area where we would say that should be, if nothing else, make sure community is in the room and at the table and has a voice, and that it's more than one engagement session.
Yeah, I would say, supporting policies that promote digital equity across all patients, including broadband infrastructure build out, access, and affordability of digital devices and services. I would, at least that is a call out. So.
I would say that the effort has to be sustained. We do go through this boom and bust cycle in public health, and everybody's focused on this now, but is it going to be there in 2 years? This is not a 1 to 2 year project. This is more like a 5, 10, 20-year project and ongoing, to be honest. So that's what I would say, and it cannot be top down.
I would say two things. I would say let's not forget the lessons that we've learned over the last 18 months. To Dr. Fine's earlier point, there's been some great things done in response to this. The second thing that I would say is also don't overlook the historical investments that have been made and the partnership opportunities. I think Again, to Dr. Fine's point, a one-time shot in the arm of 2 to 3 year funding is really great, but typically innovation happens where less resources are available and you have to come up with creative solutions to your problem. So I would actually advocate for taking, the vast amount of funding that's, been put on a 2 to 3 year timeline and spread it out by 10 and say, come up with some better ideas about how to get this work done, and let's push towards leveraging historical investments than trying to build something net new with a huge pot of money that is going to run out in 3 years, and then we've got to figure.
Well, thank you so much. All wonderful points. I was taking some notes, so perhaps we can share all those lovely high-level points out. But it was a wonderful conversation. Like Dr. Fine said, I wish we had much longer to continue having it. But thank you so much for your participation, and I will turn it back to the host.
Great, thank you, Molly. And thank you to our panelists here. It was a great, as everyone said, it was a great conversation. Obviously, it was just the start to a conversation, and building on all of the other discussions that we've had today. I think it's clear that these are important issues. They are tough issues. There are conversations occurring daily on these issues, and yet there is more that can and should be done moving forward. So it's my job here to sort of wrap things up. And you see my contact information there on the screen. I think if I were to highlight some takeaways, I mean, certainly there was, a lot to digest from today's event, and we will be doing sort of a wrap up email and sending out the link to the recording and other materials after the session. But if I were to digest just a couple key takeaways, I would say, one, across the board today, it seems like everyone agreed that data and technology are at the heart of, are going to be and are at the heart of healthcare moving forward. And that includes public health, it includes medical care, and it includes potentially also, wrapping those things together with the social services supports. We heard all of those themes referenced throughout the event today. Another key takeaway is just the interrelated nature of the two topics that we discussed today. So health equity and public health, certainly topics that go hand in hand, even as they may be talked about separately as well. So like many things in healthcare, some key dependencies and some common areas of opportunity, and also some common areas of challenges as we move forward. One of those key areas that's sort of, a heads or tails opportunity or challenge that was referenced throughout the day was data standardization. How to standardize the data, what data to standardize, making sure that data that is necessary is collected and maybe a targeted way. We heard Sean Martin and Sean Robbins at the beginning of the event talk about not just collecting data for data's sake, but really collecting the information and data that is needed to make key decisions. We've also talked about today making sure that once the data is collected, not just that it sits in some database somewhere, but that it gets to the folks that need it and can make decisions with it, whether that's the patient or another provider or another entity that has need for the data. So certainly that information sharing piece. Even as we talk about, the standardization that needs to occur for collection. And then again, another thing that we heard is the appropriate use. So we've collected the data, we're going to share the data where it's appropriate, but how else is it appropriate to use some of the data related to health equity and public health? So I think, as I mentioned, we will be we'll be posting information from today's session on our website. We will also be publishing a white paper after this event. So we will make sure that everyone that was here today gets that distribution. We will be teasing out, some of the key takeaways that I just talked about, but also other key takeaways from throughout the panel. And again, we'll be making that available via Twitter or website. It will be, a short time after the event here today. So I think with that, I will just go ahead and wrap up. You see my email. We are also, as mentioned at the beginning of the panel, we're on Twitter at HIT Roundtable. You can follow us there for any further updates, including the date for release of the white paper and the link to the white paper when it is released. And we'll make the recording link available there as well too. So thank you for spending your morning with us. We really appreciate, we know time is short, and so we appreciate everyone that hung on with us for all 3 hours, and in those that were able to join for various parts of the morning. So thank you so much, and please do stay in touch on these important issues.